We will start in about 3 to 4 minutes. Okay, we'll wait for the rest to come out because we just sent the link out and some people might be struggling with Zoom. So we'll give it a while more before we start. In the meantime, if you guys can just put up into the chat box on when roughly your exams are, like your date, I think that'll be easier to know what kind of a group that we've got today. So just the month. You don't have to put the specific date, just the month is fine. Right, so we have August. Okay, fair bit of July, people. Fair enough. Fair bit of July. Aiming. So we have candidates who don't have a date yet. Fair enough. Fair enough. Okay, so we have a couple with no dates. Can, no worries. I'll adjust the session accordingly and let you guys know differently on how different month candidates should absorb every section of the session. All right. Cool. Okay, we'll give it a couple more minutes. We also have AMC2 aspiring candidates. Okay, as we are waiting for the rest, considering the fact that I'm going to be doing mainly on history structure, MSc, MMSc, and hopefully if we have time, I can run through alcohol and smoking counseling structure. Can you guys let me know what's your biggest concern given these? Just quick type on what are your worries and concerns while I grab a paper and pen to quickly pen them down so I make sure to address them at different junctures of the session. Okay, so you guys can do your typing while I grab. Yeah, what about MSc, Abdullah? Like MSc is so huge. So what? Okay, I know that it's difficult, but which part of it, if there's any specifics? Yeah, I'll be back after I grab a pen. Okay. Oh, okay. Very, very emotional on I hate MSc. Yes. Well, MSc is very nice, very exciting. Yes, thank you. Someone said MSc is easy. I hope you mean it and you're not being sarcastic. Okay, MSc can be a little bit tricky at times, but for me, I love psychiatry. It's my favorite out of all the different subjects that are out there. Yeah, so there is a different skill of set to do between a video MSc versus a normal structured MSc. Okay, let me just pen down stuff that you guys have said. So we're talking about handling. So handling the role plays, I think that's a valid. Okay, what else did you guys? MSc in general, counseling patients. Okay, what else do we have? Building rapport. Fair enough. I will tap that when I do the MSc section of it. Um, Muhammad Zishan, you mentioned context of case. What do you mean by that? Yeah, so yeah, so letting the RP open up. Okay, cool. Anything else you guys want to mention before I start the session? Anything else you guys have? All right. Now, today we will be covering a couple of things, as I mentioned, and I also mentioned how I love psychiatry. So this is psychiatry for you. Um, okay, cool. Let me just read them by reading the stem. Now, this session will be relatively interactive. I'll be using the chat box a fair bit. So if you guys do have questions, please put in the chat box. I do always have it open at the side of it. If you guys have any questions, of course, you guys can always contact the Med Exam expert people, consultants as well. Now they are also having a AMC 2 session for 3 month session starting in on the 3rd of July. So if you guys want to know more about that, you guys can contact them and they will let you know all the information about the session. Now, before we start, just a little warm-up activity, something that I'm trying very new. So all you guys got to do is to put your thumbs up sign or the thumbs down sign. Okay, just show me if it's a yes or no based on the various statements that I am going to post on that you can see on your screen. Okay, so this is the first statement. True or false, correct, wrong, opinions. So thumbs up, thumbs down. That's it. Confidentiality. Thumbs down. Okay, what else? False. Any other emotions? Okay, I can get to see people's reactions. Cool, very good. Majority of thumbs down that I see as I'm scrolling through. Yes, so yes, it is a thumbs down. We will be tackling MMSE today as a screening tool. You can't really tell depression from MMSE, but you can say that the patient performed poorly because concentration is a one of your criteria when it comes down to your major depressive disorder, right? Lack of concentration. So a patient with depression may perform poorly on an MMSE due to poor concentration. That is one way to look at it. So not a direct statement, but in a way it can affect, not a diagnostic tool. Okay, fantastic. Next statement. I've only got about 3 or 4 statements. So next statement. A patient with schizo always lacks insight. A patient with schizo always lacks insight. True or false? Well, I scroll to see all your thumbs up, thumbs downs. This one, you need to think a little bit more. Okay, can be, but not always. Okay, I have a couple of thumbs up, a couple of thumbs down. This one is a bit confusing, right? In the first statement, we all were super sure that, yeah, 100%. Here we are like, not super. So in reality, okay, insight actually varies. It really varies based on the situation. Impaired insight is more common in patients with schizophrenia, but it is not always the case. So until you have asked your correct questions, you won't know the answer. And later we'll be looking at different ways to ask insight. I think many of us only know the question of do you think you need treatment? Do you know what's wrong with you? These are the simple questions that we always know, but there are so many other questions. Okay. Next statement. Mood and affect mean the same thing. Mood and affect. No. Okay, very strong no. Any other? No, no. Okay, at least you guys on the correct page. Mood and affect are two different things. Now, I think somebody's microphone is on and is giving a little bit of background air sounds. If you guys can just turn off your microphones, that'll be fantastic. Yes, mood and affect are completely different. So we will be looking at affect and how do you explain range? What is reactivity? What is all of these things? A lot of times we memorize affect, but people don't really understand what they are saying. So mood is pretty much on how the patient has been feeling, what the patient tells you. But affect is what you as a clinician observe. Okay, last statement. Very easy one. Very easy. The MSc starts when you begin asking questions. Yeah, so MSc starts from the moment when the patient enters, when you and the patient make the first contact, right? That is when your MSc starts. You start looking at the behavior, eye contact, the way they have groomed, what are they doing? Are they looking up and down for any kind of other kind of voices? Starts from the beginning. Okay, so you guys on the right track, so which means basics are quite strong. Okay, fantastic, fantastic. All right, now let's take a little look at structure. If at any one point in time you guys are confused, put it in the chat box. I will definitely address it. Now, there is a very wide range of doctors, all the way from some sitting in June, July, August, and then some with no dates yet to book. If you are a late June candidate or a July candidate, listen to the structure, but please do not change too much of your structure because you do not have enough time to change your structure. I don't want you to panic. I just want you to take things that will value add your station and only take things that you can resonate with. If you can't resonate with what I'm saying, don't take it. Very simple, right? And if you don't understand, question me. I love being questioned because it makes me think as well, right? For those doctors who are studying August, you guys still have a chance to adjust your structure, especially those who haven't studied psychiatry. So I will take it a little bit slow in this session. It's going to be a slightly longer session, so I hope you guys find it exciting. Now, this is the typical structure that many people have when it comes down to psychiatry, right? Now, many candidates always tend to worry and be like, oh, when I look at the station, how will I know if it's a psychiatry station or not? How will I know if it's a med search station or not? Now, the rule of thumb is simple. It is always medicine and surgery unless otherwise you can't find an answer in med search, then you move on to psychiatry. And before moving on to psychiatry, red flags med search differentials need to have ruled out. So what do I mean? For example, in a station where somebody comes to you with tiredness, I think that is one of the most confusing stations because it can go in any direction. In fact, palpitations, shortness of breath, they all have, even chest pain, they all have a touch of med search, but they also have a little bit of, it can still go in psychiatry direction. In those cases, I still need you guys to explore a very good history of presenting complaint without running away. So everything about the tiredness, when, how long, first time, intermittent, gradual, sudden, morning, night, when is it worse, what's elevating, aggravating, figure all of this, rule out a couple of organic causes and red flags for your tiredness, which predominantly in the tiredness station, malignancy is a very big red flag. Any kind of infections like meningitis are also red flags you need to catch. Rule them out, and then you start proceeding over to psychiatry. So I will spend a little bit more time in this tiredness cluster later part. Okay, I'll come back to it, not to worry. Once you have finished your basics based on the symptom that you have in front of you, then you move over to psych. Now, there are a lot of different structures out there, I understand, from many different providers, but this is a suggested structure: mood, sleep, appetite, suicide, delusions, hallucinations, followed by ICNJ, your insight, cognition, judgment, and then your sad history and hits. Now, many candidates like to or have suggested or prefer to do HITS assessment very early in your station. So you either do it right at the beginning or you do it right here after mood, sleep, and appetite. There's only one thing I have to tell you guys on why this structure is preferred. Now, if you look at HEADS assessment, yes, the trigger factor is important in every station, right? Every patient has a trigger factor. You need to figure it out. But my question to you is this: will knowing the trigger factor change your diagnosis? Will knowing the trigger factor change your management? Any answers? Any thought processes? Yeah, Hafsat, very fast. Thank you. No. The answer is no. Whether this patient break up, divorce, somebody passed on, something bad happened, lost a job, I am not going to change the way I manage the person. I am still probably going to refer to CBT. I am still going to give SSRIs if it's an anxiety-based or depression-based case. I'm still going to do everything the same. Therefore, you doing HEADS assessment doesn't change the story for you, doesn't change the way you manage the person, making it less important. Then identifying if this person is suicidal, management changes. This person is delusional, diagnosis changes. Hallucination present, diagnosis also changes, right? ICNJ, the minute cognition is not intact, it's delirium. Therefore, overall diagnosis changes, followed by your management also changing. I am so sorry. I actually forgot that there's people who do not know much about HEADS assessment yet. So anybody wants to help Dr. Srimati on what exactly is HEADS assessment? So for those of you who are new, okay, while you guys are typing and helping Dr. Srimati, let me just mention. For those of you guys who are new, this is an ideal structure that we use to follow when it comes down to psychiatry. HEADS assessment, anybody typing before I say it? Yes, okay, thank you. Rainiera, I hope I pronounced your name right. So yes, home education. Now, anhedonia, yes, we can put that there. Usually we can also say activities in general. Okay, education slash employment is up there for you. You want to know about their work or education, both of it. And A, you can put anhedonia, or you can also put activities to see what kind of activities, what kind of hobbies, or do they still like what they are doing, right? And of course, your D will be your drugs and alcohol. S for substances. And you can also include sex if you think this case is taking towards the angle of I need to figure out how their orientation is. I need to figure, especially in cases where you have gender incongruence, gender dysphoria, those are angles you need to look at in your stations. Now, Brian, you put systemic causes in your S under hits, too far. It is too far. Your systemic conditions and issues, if it's med search related, it has to come forward, right? And then everything else. So please make the switch. Thank you guys for helping out. You guys are really nice. Okay, so given that those who are doing the exam really soon, I know it's very difficult for you to readjust, but those of you who are in July, end part of July, and who are in August especially, you guys can afford. Chris, sorry, when I say med search, med and search. Okay, med search is medicine and surgery differentials. So problems which are very more common. So we will do a tiredness question later, and I hope you can apply the medicine and surgical differentials before you apply psychiatry conditions to your case. Okay? Any questions with regards to why there's a little bit of a rearrangement in the structure before I start moving into mood and sleep? Any questions, continue posting. I will definitely tackle them. Now, with regards to mood, very easy, very straightforward. How is your mood? What is your mood? Tell me, if everything been going on, how have you been feeling? Very easy, very straightforward. Let's come to sleep a little bit. I've always mentioned that sleep is very, very powerful. Many of you guys skip sleep thinking it's not important. But when you ask someone, you ask them with an open-ended question first. So if you look at the tips from Examiner, the one in the AMC website, you would realize that they would tell you a lot of candidates are asking leading on questions, or they're asking very yes, no questions. So what does leading on question means? No, you don't have fever, right? So you don't have fever, right? So what am I supposed to say? Yeah, I don't have fever. Or if you ask for, are you happy? Yes. Are you sad? No. So yes, no questions and leading on questions is what I mean. These questions are not very preferred in the AMC when you are starting your case. Whenever you are starting, go in open-ended. As you go through your station, once you start figuring out, okay, I think I know where this case is going, start narrowing your questions. Now, with regards to sleep, open-endedly ask, how has your sleep been like lately? If the person says it's bad, a person says it's good, good, move on. If the person says it's bad, you have to explore. What do you mean by bad? Do you mean any kind of early morning wakening? So early morning wakening is it's a feature of your depression. Or are there any kind of thoughts keeping you up awake? So anxiety feature. Any kind of nightmares that are waking you up, PTSD features. So sleep is very powerful in giving you a couple of differentials. So based on the comment on the chat box. So in short, we must rule out organic causes before making diagnosis of psych. Yes. Every time medicine and surgery first, then you move on to psychiatry. So it's a diagnosis of exclusion, essentially. Okay, don't do the swap over. If you do psychiatry without exploring a single medicine and surgical differential, you will be marked down. Okay. Now, when coming down to appetite, generally, now in depression, your appetite will be lack of appetite or loss of appetite. I don't feel like eating. In mania patients, they're like, I don't need food. I live on air, doctor. God loves me, so I don't need food. So the appetite will be not needed, right? No appetite because they don't think they need food. Otherwise, in eating disorder cases, you have to spend time on appetite. Now, in the chat box, let me know what are questions you would ask for eating disorders. How would you screen for eating disorders? Okay, fear of gaining weight. As an appetite question, so vomiting, yes. Crash dieting, describe your diet, laxative use, craving for food, do you binge eat? Now, if you realize a lot of the questions that you guys are mentioning are very diagnostic criteria of eating disorders. right? We are talking about screening question in general. Now, and let's go back to another question. You guys did post about, do you have any fear of gaining weight? If you ask about, do you have any fear of gaining weight? It's a yes or no question. It is not an open-ended question. Therefore, a nicer way would be, what do you think about your body appearance? So how's your appetite been? Any changes? Yes, so how do you feel about yourself? How do you feel about your body appearance? A little bit more. So for Kevin, you mentioned how do you feel about yourself? It can overlap with mood a little bit. You want to go for appearance. So how do you feel about your appearance? If person is not happy, then yes, now you want to follow up. What do you mean? Are you fear of losing, fear of gaining weight? If it's a positive, then move on your binge eating, your crash dieting, your laxatives. So screening question is very different from diagnostic question. So appetite, how's your appetite been lately? Open-ended question. Then move on to how do you think? What do you think about your body appearance? Okay. Yes, Reham Zaki, you can talk about what do you think about your body weight as well. No major issues. Appearance also okay. No. Now, Fahad, how often do you check your body in the mirror? Now, what do you guys think about this question? I hope you guys don't mind me calling out your names when you guys are posting, okay? It's learning for everybody. Okay. So how often do you check your body? Yeah, so Tima mentioned that that's a very BDD question. Therefore, it is not really. Anybody want to say anything though someone's mic is on? Poonam, your mic is on. Let me know if you want to say anything. But yes, now Hafsat did mention, right? So asking somebody how often you check your body in the mirror. Very good. I see you guys catching things in the station. Fantastic. Now, yes, it can be a question for body dysmorphic disorder, right? What's the question again? How often do you check your body in the mirror? But someone going to check the mirror often is not really a BDD question, isn't it? It is a frequency question of OCD, if you want to be very specific. And the fact that they are going to the mirror to check the body part, it is what makes it a body dysmorphic disorder case. So let's now, given there's a lot of concepts going on, let's take it slightly slower. Okay, so reverse back onto, I'll start from appetite and then I'll break it down. So during appetite, you do basic screening. How can I tell me a little bit more about your appetite? If you think the answers are shaky, move on to what do you think about your body appearance? If again you don't like the answer, focus a little bit more into diagnostic eating disorder questions. You want to talk about binge eating, crash dieting, laxatives, and all of those things, right? Now we move on to the BDD concept, the body dysmorphic concept. If you ask somebody how often they go to the mirror, it shows you are narrowing the case very quickly. I'm only asking you to do the beginning of a history. You still don't really know what is going on in the station. So when you talk about body dysmorphic disorder, it is a type of OCD. OCD is a type of anxiety. Do you guys see the layers? So it is BDD here, followed by OCD, followed by anxiety. So if you want to tell me somebody has body dysmorphic disorder, so for those of you who do not know what body dysmorphic disorder is, it is a condition where the body parts are normal, but the brain, okay, the patient and the brain thinks that, hey, my body part is not normal. I need a surgery. I need to hide it. It's probably getting bigger than usual. Or I look at the mirror, I'm like, oh my God, my nose is crooked every single day. I'm like, oh, I think I have like triple eyelids and I only one double eyelid. Something is wrong. So the mind perceives the body part to be abnormal, even though it is normal. And ideally, there is a diagnostic criteria of 6 months when it comes to body dysmorphic disorder. Okay, minimally, they must be having these feelings and thoughts for 6 months before you can diagnose it. So considering these are the layers, to get body dysmorphic disorder, you need OCD features. So Dr. Ayan has mentioned OCD, which essentially is obsessive compulsive disorder. O is your obsessive thoughts. So you thinking about your body part and thinking that, hey, my body part is not normal is the obsessive thought. The compulsive action is that I need to go to the mirror to check how my body part is because it feels like something is wrong. So there are two different things in your station. Did I confuse people? Was it clear? You want me guys to repeat the OCD concept and the BDD concept? So which means when it comes to body dysmorphic disorder, I need you guys to explore the body parts explore the OCD touch of it, of going to the mirror very often. And it's just not about going to the mirror, right? It's the frequency of it. Because if someone thinks that, hey, my belly looks a little bit bigger today, maybe because I ate too much, and then I go to the mirror 3 times to check if it's big, that's not really an OCD. That's not really a BDD because my belly was really big after I ate. But then if I start going to the mirror about 20, 30 times, then that now becomes a BDD concept. Does that make sense? Okay. Now, new concept that you guys are bringing up is based on gender dysphoria. So ICTCMD said OCD, dot, eating, somatic. Can you elaborate? Okay, I get what you mean. Yes, they are all different types of no, they're not. So with regards to OCD, OCD is a type of anxiety. Okay, we got that clear. But not everything falls under OCD because, for example, in your gender dysphoria case, there is no kind of obsessive thought and a compulsive action, isn't it? What is the obsessive thought? What is the compulsive action? If you can draw these two, then yes, it is an OCD station. If not, it is just under an anxiety cluster. Even for eating disorders, it is not really an OCD. It is an eating disorder under the anxiety cluster. Any more clarifications? Now, I will tap on gender dysphoria and gender incongruence when I come in later. Any confusion so far? So far, so good? Okay. So we covered mood, sleep, appetite, tapped on a couple of anxiety disorders. Okay, that is for additional concepts. Now we'll move on to suicide. Suicide is a very big, important part of your AMC clinicals. Nowadays, if you do look at the task, they are starting to ask you guys or tell you guys to do a risk assessment, an assessment, right, of risk. If you don't read your task very carefully and you end up doing the entire history from head to toe, you are not going to clear the station. Please always answer the task. So here's something I have on suicide. Have a little read before I take you guys a little bit more through. I think most of us know how to ask suicide questions. I don't think we struggle with it, but I think the risk part is something that we struggle with. I took this from Telly O'Connor. So most of my resources or knowledge comes from Harrison's, Telly O'Connor, John Murtagh, Oxford books. That's where I always double check to make sure I'm on the right track whenever I give you guys any kind of information. Now, simple questions of asking suicide. Have you thought life was not worth living? Or very simple is, do you happen to have any thoughts of self-harm or harming others? Now, before I explore a little bit more into suicide, okay, let me reverse a little bit and talk about confidentiality. Confidentiality is important in psychiatry, but it's not the most important thing in psych. When do you establish confidentiality? Ideally, as long as you establish it right before you ask your mood question. So after you finish HOPC, after you finish organic causes, you establish right before mood, enough. And your confidentiality statements in psychiatry would be, everything we discussed today will be confidential unless otherwise harm to you or others. I need you guys to include the harm statement in psychiatry confidentiality statements. Just telling me that, oh, everything we discussed today will be confidential, yeah? Not enough, because there is a room of harm in these cases. Now, otherwise, your non-harm stations, so in stations where you're talking about, let's say, breast issues or vaginal discharge or other kinds of med-surg cases, you don't really need to say unless otherwise harm to you or others. You can stop at everything we discussed today will be confidential, full stop. Move on with your station. And even then in those stations, when it comes down to non-psychiatry, you will have to establish it either right at the beginning, especially if you're a guy and the station starts with vaginal discharge or breast issues. I need males especially to do your confidentiality at the beginning. But if you're a female, you can close half eye or one eye and start doing your confidentiality right before you start touching into sexual history in those stations. Does that make sense? So please be very practical about confidentiality. Don't just start throwing it in every station because someone said so. I need you to understand the rationale behind your confidentiality statement, not just throw it around. In this case, do it before mood. If you didn't do it before mood, before suicide, you must at least shoot your confidentiality statement, then ask your suicide questions. So with that said, let's move on to suicide. Very simple, your suicide questions, but let's explore a little bit more. If suicide assessment is asked of you, I tried to find an easy way to kind of put the assessment together for you guys and how to talk about risk assessment. But there was no easy way. I realized that suicide is quite heavy, and because there are specific tasks on suicide risk assessments, I need to spend time talking about it. Now, we've got a very quick question in the chat box, so let me just address them before I move on. So Abraham asked, for STI, do we need to mention unless otherwise harm to you or others? No. We are talking about harm in sense of suicidal, life-threatening harm, killing, violence along that direction. So can you repeat when and not to use unless there is? So if it's a psychiatry-based station and you think that there is a chance of suicide or harm or there's hallucinations and they're listening to commands of like, oh, the voice is telling me to go and kill my friend, you see these kind of pictures going around you. Generally in psychiatry, before you ask suicide, you would establish your confidentiality statement with your unless otherwise harm to you or others. In other stations, especially medicine and surgery, you don't need to. And if you feel that you're doing a medicine and surgery case and you didn't open up with the unless otherwise harm to you or others, but then you realize that this patient is not telling me, feels like they're hiding something, go ahead, establish it and see if the story changes for you. Okay, no harm doing that. Now, coming back with regards to suicide assessment, very thorough. We will take it step by step. Amir, you have a question? So Amir, you asked about example for body dysmorphic disorder. So usually in the body dysmorphic disorder station, the STEM would already tell you that the patient wanted a breast reduction surgery. If you are a male and your patient is coming to you with a breast problem, after you go, how can I help you? And then she goes, oh my God, doctor, my breast is so big, I want to make it small. You have to immediately establish confidentiality. But the thing is this, you can either do with without harm at this point in time, because in your head, you don't quite know if this is a station of psych or is this a station of just her breast is big and maybe it's going towards cancer. So in such a situation, you can afford to do two different confidentiality statements. So your first one as a male will be just everything we discussed today will be confidential. I know we're talking a little bit of your private organ, so I'm just going to establish it and then you start talking. When you realize that it's going towards a body dysmorphic disorder concept, you can now go, everything we discussed today will be confidential. I'm going to reassure you that unless otherwise it's harm to you or others. Is that okay? And then you continue your station. Does that make sense? So you have to play by ear in your station, make it as practical and real as possible. Because you only know the station is BDD is because you know the recall. Because if you don't know the recall, you actually wouldn't know that's a BDD case. It will come to you as someone has big breasts. I don't know if it's cancer. I don't know if she's lactating. I don't know if she's pregnant. I don't know what's going on. So that will be the thought process, okay? Now, let's go on with suicide. First of all, assessing your intent is very important. So what do I mean? A person can have thoughts, but no intent. So yeah, I think not living will be nice. Yeah, maybe I don't want to live, but I have no plans. I don't intend to not live. It's just a passing thought. So this is what we call as your suicidal ideation. So thoughts are there, but I have no active plans going on or no past attempts, okay, depending how the story goes. So questions would be, do you think you would act on these thoughts? So what are these thoughts? Do you think you would act on them? Have you come close acting on them? So assess if they actually have intentions to die and suicide or kill somebody, or is it just an ideation? First step. Then you want to move on to, if that is a positive, now start going a little bit more deeper. Are there any kind of plan that you have? So have you thought about how you're going to do it? I need you guys to be very thorough. So talk about when, where, have they got any tools, any knives or any kind of glass? What have they prepared? Any poison? I need you to figure out the plan, because the more thorough the plan is, the higher the risk of them actually taking up the plan. And this will change the level of risk for you when you are presenting. The reason why I'm spending so much time in suicide is also because in the MSc presentation, you need to speak about risk assessment. Therefore, all of this will come into play together in the MSc. So I'm taking it just slowly in this case. Now, once you've figured out, you want to proceed on to asking the means. So this is where I kind of overlapped a little bit more with what have you bought already. So any firearms, toxic substances. Now, one thing to take note in Australia, in the rural areas, okay, there can be means to firearms. So just double check on where you are in terms of location in your STEM. But most of the times the STEM are very metropolitan areas, not really rural areas. So just double check on that one. A person who's had previous attempts also has a higher risk, it's a higher risk predictor for future suicide. So these are things I need you to explore if suicide is a positive. So screening question first. Do you happen to have any thoughts of self-harm or harming others? Answer is no, move on. Answer is yes, you got to sit and explore all the various pointers that I just mentioned. Any question with regards to how to explore suicide before I tap on risk factors and protective factors? So if you figure out that this person has a plan or some kind of ideations, you want to start exploring on what kind of risk factors. Now, many of these risk factors on, not to encouraging, but making someone at a higher risk or predictor of having going into suicide would predominantly lie in your HEADS assessment. So this is additional story you will collect when you reach the HEADS assessment. So your psychosocial, the social part of your history. Fair enough? And of course, even the protective factors, most of it will also come from this social part of your history where you ask about the family, about kids. If you have time, a little bit on what kind of plans they have for tomorrow. All of this will come under protective factors, things that prevents them from acting on the suicidal attempt or the plan that they have. Any questions on suicide before I move in a little bit more deeper? I know some of you guys might be like, wow, I never knew there was so much to the first part of psychiatry history. Was this mood, sleep, appetite, suicide, HD, ICJ? You used to run through the nine questions of psychiatry. So usually, for those of you guys who are not sure, this five, is it five? Want to know this six: mood, sleep, appetite, suicide, hallucination, delusion, and IC and J. These are your psychiatry history. Then HEADS assessment together with smoking, alcohol, and drugs and substances falls under your social history, which is why we call it psychosocial history. Why I need you guys to know the difference is because there are certain tasks in the exam specifically tells you that do not take the social history, but only take psychiatry. So for those of you guys who have mixed your histories together and you don't know the difference between social and psychiatry, you will fall into a trap when you see these kind of tasks, because now you're going to be like, crap, what do I ask? What do I not ask? It's going to put you into an engine brake, which is why I told you put psychiatry together and then social alone on its own. It's easier for you to remove and add if the station says don't do it. It's actually quite common nowadays because they are looking at your skills in various ways. Now, with that said, we'll move on to insight and judgment. So these are your basic definitions of insight. So insight is just seeing if how much or how well someone understands the problem. And judgment is just seeing how they behave. So are they acting or giving me answers or behaving in a way that society expects them to behave? That's what judgment means. Now, this is where in these two questions is because we only know what is insight in terms of and do you need any help, do you need any treatment, versus judgment of the favorite question we all know is, if this room catches fire, what are you going to do? The problem comes when you have a video station, because there are many ways to ask insight and judgment. In a video, you don't have the liberty to ask your own history questions. You need to listen to somebody and assume like, yeah, sounds like there's insight, sounds like there is judgment. So I will expose you guys to a couple of different questions and hope you understand it a little bit more. In fact, if you guys, for those of you guys living in Australia, right, there's so many roundabouts in Australia. Every corner you go there is a roundabout. And in a roundabout, you actually need good judgment, right? To know how to maneuver through a roundabout, you must gauge the speed of the car that's coming. You must gauge, are Are they taking the inner lane or the outer lane? How many lanes are there? So going through a roundabout actually is a positive output of judgment. So person has judgment if they can go through a roundabout. Now, Anita asked on the station and in the chat box, what are the psych and what are the social? So mood, sleep, appetite, suicide, hallucination, delusions, plus your insight, cognition, judgment. So the middle portion of it, okay, the middle portion of it here, the 9 questions. These are your 9 psychiatry questions. These are purely psychiatry, nothing to do with social. Now, your alcohol, drugs, smoking, home, education, environment, activities, all of this falls under social history. You're finding out about their life in general. Therefore, we put it as psychosocial history. So psychosocial history. Now, the other reason why, if you look at my slides, I have put A and D on top, and S is very small. So S is smoking, okay, A and D is alcohol and drugs. The thing is this, smoking does not affect your judgment, does not affect your, if smoking does not affect anything in terms of psychiatry, yes, it affects your lungs, it affects your respiratory, your cardio, and as a cardio risk factor. In terms of psychiatry, it does not actually affect anything. That's why smoking is a very small portion. And alcohol and drugs is, I've put it in front compared to your health assessment. Reason is because, again, same concept, right? If a person divorce, breakup, or whatever happens to them, it doesn't change my management or doesn't change my diagnosis. But if a person is consuming alcohol, if a person is consuming drugs, it can fall under substance abuse and it can fall under excessive substance, like abusing the substance. And when you talk about alcohol, which I will cover when I speak about risk in the MSc and during the alcohol counseling part, you need to know how to figure out what level of risk this person is because he's consuming alcohol, he's not aware of the safe limits, or he's breaking the law, he's trespassing, drunk driving, a lot of things to think about. And this affects your psych. Therefore, alcohol and drugs is higher compared to your HEA part of it. Halima, you asked if the patient doesn't believe that he has a mental illness, does it fall under insight or judgment? Insight. But I will come to it later. It's insight, but I'll come to it later. Now, let's talk a little bit more about insight and judgment. Now, a little bit deeper. So insight is just assessing if the person knows there's a problem. The person understands that, yeah, maybe because my husband passed away, that's why I'm feeling a little bit sad. So understanding the cause is also a type of insight, right? And knowing that, yeah, if I drink a lot, I'll probably have like some liver problem or something. Understanding the consequence or the risk is also insight. So here's a couple of questions. So have a little read, I know quite a lot, but these are different questions that I found from different books and resources and try to squeeze them together into different sections on what can insight be. So if any of these questions are asked in your video, actually is an insight is present or absent, it's an insight question. The slides will be most likely given to you guys, so you guys can take a look at these questions after that. So there are different ways of understanding. And I think especially because many of us come from IMG, we all are IMGs. Our command of English isn't the strongest, and our not in command of English, but vocabulary and the way that Australians ask questions, especially in the video, we might not understand that, which is where the problem comes in. So as long as you're aware there are different ways, and your brain shouldn't be, I need to wait for that question of, do you need help? It's not going to come out that way. Now, this is judgment questions. So what is it about judgment? So for judgment, as long as the person is behaving according to social norms and the person knows that, yeah, I'm doing this because of this, and this is the right thing to do, that is judgment. Now, let me just take a look at the chat box. Sidra, you asked how many questions to ask. One enough, man. You just want to know if it's there or not there. Finish. If you think the first question you ask, you yourself are not very sure, then ask a second one. But if you've gotten your answer, move on. So once you got your answer, move on. Now, Ayan is asking, just asking that, do you think you need medical help suffice to? No. So one question is enough. Now, the problem is, do you think you need? So when I had my exam in my first psychiatry station, I asked the person, I used to ask the person, are you aware of what's happening? The guy looked at me like I asked the most weirdest question on the planet. And I was like, crap, why is he looking at me so weirdly? He didn't understand my question when I asked, are you aware of what's happening to you? So subsequently, I changed my question to, do you think you need any kind of treatment for what's going on? And that question is usually enough to take you through your psych stations, if it's a history taking station. So one is enough, don't need to probe. And Ayan, you asked me if you need to probe. Now tell me, what is your rationale behind probing? If you can justify to me, then fine. But if your justification is not working, don't need to probe further. So what are you probing for? What do you hope to get by probing? What is your justification? Any thoughts? You just type in and I'll look at it. Now, the reason why when I do judgment, I always use the fire question is because I genuinely don't really know the answers to the rest. And because if you look at the social judgment, right, this question, I love to bring this up. What would you do if you found a stamped addressed envelope on the street? To be very honest with you, if someone asked me this question, it really depends, man. If I'm having a busy rush day, I might just look at it and walk. But if I have a lot of time, maybe I will take it and I'll put it like on the table at the side. And if I have extra time and the post letter, like the post box is nearby or there's some post office is nearby, then maybe I'll put effort to go and put it in. But there's so many variations. The thing is, everything can be okay. There's no 100% right or wrong answer. So try to stick to your fire question because I think that's 100% right thing and a wrong thing to do in terms of social. However, the rest is a little bit shaky. And you definitely need more time to explore those. Ayan, well, no, you don't have to explore any further because knowing whether he needs medical help or whether he thinks he needs medical help is not going to change anything for you, isn't it? As long as you've gotten your insight, move on. You're not valuing anything of psychiatry aspect of things. Sorry, the fire question is, if this room caught fire, what would you do? If this room caught fire, what would you do? Oh, I didn't type that in. Sorry. Sorry. If this room caught fire, what would you do? That's your fire question. Usually the one very common, even in telecon, it's like the first one. In your John Mutakan was the first question because it's the easiest. Any question for judgment and insight? Okay. Do you guys need a break or can we push through a little bit more? Do you guys need a break or we can push through? Push. Okay, let's push. AMC exam is longer, isn't it? So we can definitely push through this. Fantastic. Love your spirit. So therefore, this slide is cancelled. Okay. Okay. So now we're going to start tapping on MSc. Before that, any questions with regards to your history structure? Let me tap a little bit on past medical history. A lot of you guys love to ask past medical history. Very good. Very nice. But why? What's the point of asking past medical history if you don't know the relevance to it and the case? So if someone comes to me with, for example, having tiredness, let's go back to that. If you ask me, oh, what's any kind of past medical history? So what are you expecting out of it? Anyways, someone's mic is on. You must go like any history you like. Okay, let me see if I can. Okay, I muted the pen. So any past medical history like, then you want to go like thyroid conditions, any kind of diabetes that you might have had. And if the person tells you, no, doctor, I've never checked for those, you must understand one thing. Just because someone hasn't checked for diabetes doesn't mean they don't have diabetes. Therefore, your follow-up should be, at any point in time, have you had any kind of going to the toilet very often or drinking more water or feeling more hungry? So your polydipsia, polyphagia, frequency questions needs to come in. Does that make sense? So just because I've never tested before doesn't mean I don't have it. Same concepts when it goes to your medicine and surgical STI concepts. Okay, you have to explore further. So please make your past medical history open-ended and then relevant to the case. That's where your marks will actually start going up in your station. It shows the examiner you are aware what kind of conditions usually comes with this presenting complaint or problem. So if someone comes to you, for example, let's go back to medicine and surgery. It's a bit more easier to explain past medical history there. Comes to you with rashes in their body. So when you go down to past medical history at the bottom, you want to spend more time asking about past medical history, either of taking medications like aspirin, any clopidogrel, any kind of blood thinners they might be taking. You want to spend time with liver conditions, family history of liver problems. So something more specific to show your clinical competence in the station. All right, let's move on to MSc. Okay, now this is your structure ideally for MSc. A lot of candidates, I wouldn't say forget, but they don't really know about this 3R. However, if you do look into your handbook and your teleo corner, you do have your 3R concept. So I need you guys to add the 3R. I know for my June doctors, it might be a bit difficult to add, but try to squeeze it in. Show the examiner you know your MSc really well. For July doctors, I think you can squeeze it in. August, 100% you can squeeze in the 3Rs. They're not difficult. Okay, please try your best to squeeze it in. Most of my doctors who do this mnemonic get through MSc. Yes, Dr. Bath is on fire again. Reliable, risk, and rapport. Fantastic. Your 3Rs. I need you guys to add that in your stations. So let's talk a little bit about appearance and behavior. Many of you spend a lot of time in your stations explaining many things about appearance and behavior. Yes, Ayan, question.
Ma'am, can you please explain the mood and effect one more time, if that's not an issue? I a little bit got
No,
joined
not an
late.
issue at all. I will come back to it after I finish appearance and behavior.
Okay, okay,
I
thank
have like a lot of slides for mood and effect. Okay, okay,
you, ma'am. Okay.
okay, no problem. Now, a lot of you start telling me things like the patient is not drunk, the patient is not having tremors, the patient is not sweating. Well, they don't matter to me. A mental state examination is to present things that you can see. So why are you telling me things that you cannot see and is not there? How does that value add to the MSc? So tell me only what you see. And this is the reason why everyone is running out of time. And when we talk about the concept of time, before I go in deeper, ideally 2 minutes and 10 seconds is all you need to present a very strong mental state examination. However, in your exam, there are stations where you have a 6-minute history followed by 2 minutes of presentation time. I need you to run a little bit if you're left with 2 minutes. In stations where it's a video of 4 minutes, you have another 4 minutes to present your mental state examination. It doesn't mean that you take all your time. I need you to consolidate a little bit more and then take about 10 seconds to yourself. Then look at the examiner and present your mental state examination. There are also stations with 5-minute prompt timers. Those ones are slightly better. So once your 5-minute prompt timer goes off, it doesn't mean that you immediately need to start presenting your MSc. You can still wrap up your station, which brings me to the difference of prompt timer versus take history for no more than a particular amount of time. If they say take history for no more than 5 or 6 minutes, you must stop asking your questions. But if it's a prompt timer, it is just prompting you to move over to the next section. So after 5 minutes prompt timer, if you realize, crap, I haven't asked suicide, I haven't asked let's say insight cognition judgment, and these are so important for me to present my MSc. Therefore, I will now quickly ask insight cognition judgment questions and move on for about, so you can afford another extra 30 seconds. So each question on the assumption you take 7 to 10 seconds. With question and answer, you can afford 3 more questions, which is perfect for IC and J. So finish up IC and J after 5 minutes prompt timer, wrap up history, move on to consolidate and presenting your mental state examination to the examiner if you have a 5-minute prompt timer. So I hope I explained the different versions and the time management for different MSc stations. Now, going back deeply into appearance and behavior, please only tell the examiner what you see. As long as in appearance, the patient is well dressed according to weather, good enough. Nothing else really matters. Don't talk about the tremors or alcohol or anything else. But things that you also need to mention are things which looks very unique in appearance. So, for example, you're doing the case with a guy who's alcoholic. Yes, he might be holding an alcohol bottle. If he is holding an alcohol bottle, then yes, you would start mentioning them in appearance. And if you see a guy who is depressed, which is a very common station in the exam, you will see the patient wearing all black, black shoes, black hoodie, everything all covered up, black nails. Yes, these are unique things you want to mention because black is a color that also represents darkness and depression. So the patient is expressing themselves through that color. Or in a mania station, if you think your patient is having let's say feathers, colorful rainbow neon colored feathers, or maybe their dress is very very unique, or they have like some kind of bubble, I mean bunny ears on them. Yes, these things you want to mention in a mania case appearance. So please pick things that matter. If not, don't have to spend so much time in appearance. If you go back to the mnemonic, right, appearance, behavior, and speech, the reason why I put appearance and behavior here, oh dear, now my screen became very small. Okay, why I put appearance and behavior here at the side is because anybody can do appearance and behavior. You don't have to be a clinician to do appearance and behavior. If you pull a medical student from your clinic and be like, hey, tell me how the person's appearance and behavior looks like, they can tell you. So your value is very little there. And many of you spend 30, 40, 50 seconds on appearance, behavior, and speech. You don't have to. 10 seconds, 10 seconds, move on. Your marks are not there. Your marks are in the middle portion of where I've highlighted. And I'll explain a little bit more on why your marks are there. So under speech, many of the times I think for speech, I've told you guys to talk only about rate, volume, and tone. So these are, let me put the next slide. Okay, so rate, volume, and tone is something that you can mention in speech. Many of you, when you present your MSc, the way you guys do it is I assessed the speech for the rate, volume, and tone, and I think a lot of other words that you guys say. And then you got the rate is, the volume is, the tone is. Don't you realize there's an overlap and doubling? So you just spent like 7 to 8 seconds telling the structure, and then now you're repeating the answer for the structure. That's 20 seconds, man. 10 and 10, waste of time. You can't afford that in the exam. So you just have to go in speech. The rate was, the volume is, the tone is, the fluency is. Finish, move on. If you struggle with understanding fluency, rate, volume, and tone. I think that's easier for everybody. You have time, you understand the case a bit more, go for fluency. Or if it's very unique in the fluency, you want to start mentioning it, like, oh, patient is stuttering, or patient is very hesitant to talk about things, or they're not pronouncing their words properly. Yes, you want to mention that in your case. Other things you want to mention in speech. So, for example, in cases of PTSD, right, post-traumatic stress disorder, it is very common that patients will talk about their life. They talk all about their life, but then when you start talking to them about the traumatic episode, maybe, for example, this person was raped, and they start talking about the rape episode, they start speaking very quickly because they really want to get over that story. That is unique in speech. So you can say that the patient's, during the consult, the patient's rate, volume, and tone was normal. However, when patient was talking about the trigger episode or the rape episode or the trigger factor, whichever words you like, okay, use those words, the patient's rate, volume, and tone increased. This is where your clinical marks comes in. You need the analysis in your MSc. Mention these things in your station. Does that make sense for speech? So there's more that you can do than just mentioning rate, volume, and tone. There's no one correct way to do your MSc with regards to that.
Ma'am, in within 2 minutes, how can we like explain everything like his trigger factor and every all such things?
So you see ABSEPDICJ, right? 3R. I did the math before, it's 11. That's why I gave 2 minutes, 10 seconds, and 2 minutes, 15 seconds. It actually can be done, but it comes with practice in when it comes to MSc, and it really can be done. The fastest that I've got a candidate doing was 1 minute and 58, or 2 minutes. You can just put it to 2 minutes. The doctor took, and it was clear. It wasn't rushed. It was very, like, clarity was there. A lot of times we speak really quickly, and the thing is, when you speak very quickly, the examiner can't give you marks, can they? Because they themselves can't understand or can't hear you. And accent is another thing you need to work with, because they might not understand our accent as quickly as we do. Therefore, you need to slow down a little bit. Ideally, I would say put aside 2 minutes 10 to 2 minutes 15 seconds in presentation of MSc and cut down appearance and behavior. You don't need to say so much there. Speech and beyond, you need to elaborate a little bit more. And you see, Ayan, yes, it sounds a lot, but if you look at IC and J, insight, cognition, judgment, they're very straightforward. No insight, intent, cognition, oriented to place, person, and time, and then judgment, intact, impaired. So those are IC and J is also speeded up. So this is why I put these parts a little bit more because IC and J is all very short. Your depth only comes in speech, emotions, perception, and your thought, content, thought form. The rest you can run through.
Okay, ma'am.
Mhm.
Yes.
Right. Moving on to speech. So I know that a lot of us do struggle with trying to find sentences. So I've got a couple of sentences here. It is not always copy and paste. Please do not always copy and paste. I need you to understand the situation is always not the same in the AMC clinicals. Therefore, these are suggestions that of words and vocabulary you can use. Situation in the exam will change, can change. So these are common, more commonly presentations of speech, but not always. I think some of you guys have asked me before, what is the difference between rapid speech and pressured speech? A lot of candidates interchange them, use them as though they mean the same thing, but they're actually very different. So rapid speech is just speaking very quickly, right? Rapidly speaking. But pressured speech is speaking so quickly and not even allowing you to ask questions. Or even when you ask questions, they continue talking. So, for example, in mania cases, they actually don't care about what you have to say. They will just talk about all their plans. And because in mania, if you do look, they talk about a lot of things. It's very messy. It's all over the place, right? Therefore, they're not really bothered on listening to you. Okay, so we'll tap mania in a bit. Any questions for speech before I move on to emotions, mood, and affect, where it's a little bit more content?
Ma'am, so can I ask my doubt?
Yeah, yeah, of course. Go ahead.
So if a patient has, let's say, a major depressive disorder, so
Mm.
during taking the history only we will understand his speech, and then when presenting the MSc we will say that he has a low speech, low volume, low tone.
What do you
Is
mean
it?
by low speech?
I mean to say that he was not speaking too much words, only few words like, okay, how was your mood? Fine. Like monosyllable wise, he was answering my questions.
Okay, so there's a lot of things going on, right? So monosyllabic is usually crafted as thought form because their thoughts are forming in a monosyllabic manner of one word, one word, one word. So I will come to thought form and monosyllabic later, but the word I think you're looking for in a depression patient is monotonous.
Yeah,
So when
yeah,
you have,
sorry.
yeah,
Sorry.
monotonous, two different things, monosyllabic and monotonous. So if I bring you back to speech, okay, here. So rate, volume, and tone in a depressed person, the rate, volume, and tone will be low actually, and tone will just be monotonous. So you can just say that very quickly in a depression patient without mixing up with monosyllabic, which is a thought form. Did that answer your question or did I confuse you more?
Yes, ma'am. It is, I understood it, but like the way of answering the way the patient will answer, on that we will say that okay, the speech is rapid or like too fast, too slow, or normal.
So all of your answers for this is based on your consultation with your patient. There is no, I think I know what you mean. There's no specific question you can ask for speech. The entire 8 minutes or 6 minutes of history is your speech. And any kind of variations is what you would mention for speech. Does that answer your question? I think that's what you mean,
Yes,
right?
ma'am.
Because inside
Fine.
cognition, judgment, all have specific questions, but there's no question for speech. It is
Same for
just your.
appearance ways.
Yes, so appearance, behavior, and speech don't really have a question. It is just you observing as a clinician.
Yes, ma'am. Got it.
Cool, cool. All right, let's move on to mood and affect. Now, mood is very easy. So I'm gonna run through mood. I'm gonna spend more time on affect. Mood essentially just means how the patient feels and what the patient tells you. So directly ask the patient, how's your mood like today? Or any way that you like to ask it. You need to remember that answer the patient tells you. You cannot forget that answer. So if you are someone who uses your pen and paper, you would write that answer down. Mood is the exact. So if the patient says, if you ask the person, how's your mood like lately? Meh. You would write down meh. And when you are presenting your MSc, you must say patient's mood was meh. You have to give the exact same word. Do not change it in any way. Okay, as ridiculous as the sound or whatever they give is. So very easy. Now let's move on to affect. Affect is where things get a bit complicated. Affect is what you as a clinician observe. So what do you think the patient feels like to you? So these are a couple of words that you can use. So do they look happy? Do they look sad? Do they look angry? How do they actually look in front of you? And this is where range comes in. So in the chat box, can you guys tell me what do you understand by range under affect?
Can you repeat, ma'am?
What do you guys understand by range? Many doctors speak about range. So is angry emotion that you observe in the affect, or is it the range? Why does angry mean range? For those of you guys who said angry. Guys, I'm not asking for rage. Sorry, I think maybe it's me. Range, R-A-N-G-E. Maybe it's me. This one, this one. Range. Yes, thank you, Lala. Yes, not rage, range. My bad, people. See, this is what happens in the exam. Right? You say one thing, role players say another thing, examiner give you another score. Okay, guess so range of emotions. What does that mean? Okay. Severity, emotions alternating, high, low. Well, for those of you guys who say high, low, so I'm a high and low. Think about the concepts of mania and depression. So I'll be talking about bipolar, right? Mixed emotions. Okay, so Beryl said, why does it mean the bowel rapidly switching? Min E, yes, hands up. Question. I saw a hand up and I saw a hand up. It's okay. Yes. So now a lot of things you guys are telling me. So most of you guys are correct. Okay, you guys do get that range is how does the emotion change during the consult? Then you guys are starting to say words like labile. Labile means that during the 8 minutes consultation, suddenly happy, suddenly sad, suddenly no feeling, suddenly happy. And these are things you observe. The person is smiling, person is cheering, person isn't like look very blunt, like face blunted effect, and then smile again is your observation, right? So how it fluctuates during these stations. Okay, so yes, a couple of restriction and fixed all of these words. So here, this slide will help you a little bit more. So basically, how much emotion the person is showing you is your range. So you want to start looking at, is it a full range where like it's normal, right? Usually when I talk about sad things, I'm supposed to be sad, usually. Right? When I talk about happy things, I look very happy. Then when you guys make me angry, I show my angry face. So that's normal. I'm having a full range of effect, normal human being. However, if I feel like I'm not really wanting to show how I feel and I hold myself back, then that is restricted effect. So my emotions, my range is very restricted. I don't really want to show you how I'm feeling. Okay. Blunted, a bit more common in your depression cases where no feeling. I just look at you, you look at me, I look down, I look away. So no major emotions, you observe. That's your blunted effect. And flat is completely zero, your voice, tone, speech, everything complete zero. No reaction at all. Just like a robot trying to talk to you. That's your flat effect. Please be aware of the different words. I feel that a lot of candidates memorize them, but I hope you guys understand why you're saying these things when you talk about your range. Now, question. What mood is this person experiencing?
Distress.
Okay. Any other words? You guys can either put in the chat box, you guys can turn on your mic. Okay, sadness, distress. Okay, fantastic. I'll show you guys another picture. Okay, hang in there with me. So low, okay. Now, teary, okay. Next picture. What's his mood? Happy, okay. What else? Happy, high. Elated, dramatic.
Just the photo or the character in the movie you are
No,
asking?
no, 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 just the photo. Not many people might have watched the movie, so just the photo. Yes, psychosis. I know where is it coming from, Hafsa. Movie. Is this the picture? Just the picture, Hafsa. Happy. Okay, cool. Now, I want you guys to know something. That was a trick question, everybody. I asked you, how is the mood? I didn't ask you for affect. Mood is something you can only get by asking the patient. Fantastic, Samantha, but you got stopped. I gave the answer. Now all woo and ah. Yes, so that was a trick question, guys. So if mood, you only will know by asking the patient. But what you guys, if I had asked you what is the effect, whatever you said was correct. Effect is what you as a clinician observe. So remember, mood versus effect are two different things. Okay, so mood is what the patient feels, affect is what you as a clinician think the patient feels. And once you match these two, if they match, it's congruent. If it doesn't match, it's incongruent. That's where your congruency comes in. So when you want to talk about affect, you want to mention about how you think it is. Okay, you want to talk about the range of it. So how was the range throughout the effect in the whole consult? Then you want to talk about was it congruent or not? So very, very practical, right? How do I think he was? What kind of emotions he showed throughout the 8 minutes? And was it congruent? Then wrap up your effect, move on to presenting. Euthymic fall, usually that will be flat, no? Flat or blunted. So usually in schizo cases, maybe. Like you, or rhythmic, you mean no, not having any rhythm when they're speaking. Little bit of elaboration, Halima, on which section you are looking at. Anita, what was your question mark for depression OCD? In the fact, never quite thought about it for you, Tami. Usually we talk about it as it can be a rhythm. Okay, but I will check and I'll get back to you in with regards to that. Can you please repeat the whole answer to mood? Which part? Which part of mood? Okay, I will try my best to repeat a little bit more in terms of that. So euthymic, so okay, let me answer the euthymic question first. For example, like now me and you having a conversation, or maybe you're presenting an MSc on a normal person. So MSc doesn't always have to be presented on a person who has a problem. Does that make sense? I don't need to have a mental health condition before you do an MSc on me. I can be a completely non-mental health condition person, but I'm coming to you for a normal consult. So MSc is something that you can present for anyone. I don't need to have a problem. Therefore, euthymic, you can either use it if what I say and what I do is just congruent with everything. I have a normal mood. I have no major ups and downs. The consult, very smooth, very flowy. Nothing is unique. So it's very similar to how in your appearance, it's just normal, right? There's nothing very fun or cool or exciting to mention about. Does that make sense? Now, to explain about the mood, Samantha, I'll come to your question. Samantha, I'll come to your question in a bit, Samantha. I'll answer the mood part. Abdul, can you elaborate on which part of the mood that you want? So with regards to mood, guys, so mood and affect are two different things. Mood is just asking the patient with everything going on, how's your mood like lately? Or what is your mood? Or how are you feeling in general? One question. Get the mood, get your answer, move on. Don't have to explore, elaborate so much. However, if it's a normal history station and you're also looking for differentials in your case, if someone tells you that they feel low, my follow-up question would be, has there been any kind of highs? So you've immediately ruled out mania bipolar concept. Or if someone tells you, I say, how's your mood like lately? And then they tell you, oh, doctor, I feel very anxious about things. Immediately follow up with, are you generally an anxious person? So GAD, quickly try to rule out things. Yes, Abdul, question.
Sorry, so my question was that when we ask the mood, so that's the question, the answer, whatever we get. But when we are presenting to the examiner, so the answer I know is that the examiner, the effect that I observe is congruent to what the patient described. So how can I make it more like I can add range or other thing in my answer?
Okay, cool. Got it. I got your question. So when you are presenting your MSc, okay, I think this comes to MSc presentation structure where we all get confused. So make it like a table form. So examiner, under speech, patient's rate, volume, and tone was low. Under the effect, patient claimed his mood was low. Okay, his mood was low. Under effect, I observed that patient did seem very low and teary during the consult. The range was very blunted and it was congruent. The affect and mood were congruent. Move on. Does that make sense? So under emotions, under emotions, talk about mood, talk about affect, then continue on with your case. So make it very, very structured. Can you show the range? Oh, sure. Here, your range slide. No, so stochasticity for restricted, right? You can see the person smiling a little bit. Like, yeah, like, oh yeah, oh yeah. When you ask a question like, oh, are you happy today? Or are you happy that your kid bought you a flower today? Oh yes, doctor, I'm very happy. And then goes back to normal, right? So like I like there are little bursts and bits of different emotions, but then they don't want to show you so much that they're very happy, right? They want to hold back and they retreat back to being no emotions. So that is your restricted. Whereas for blunted, you won't even get that smile from the patient. Yes, you get intonations, you just get a whole low feeling the entire time. Whereas flat, there's no difference in terms of tone at all. Everything is just flat. The way they speak, they're just not bothered. They have other things to do in life. They don't care about you. Not bothered but and not giving you any expressions. That will be your flat effects. That's the difference between restricted, blunted, and flat. Lakshmi asked, can we comment about masked face under behavior or effect like in Parkinson's? So now we are mixing up medical surgical differentials together with psychiatry. But if you are doing an MSc presentation on a Parkinson's disease patient, very, very complex, very technical, but your mask-like face will, oh my God, the question flew. Give me a second. You would put mask-like face under your appearance. And when you are presenting your effect, you can say that he was having affect, you would just want to talk about emotions, but you would say you were not able to get the emotions out because of his mask-like face due to Parkinson's disease. Does that make sense? You're not able to tell his emotion, the effect of his emotions because he has Parkinson's disease. So for example, if someone comes to you wearing a helmet in your station, obviously you can't tell the effect so well, no? It would be very hard for you to tell somebody's effect because you just don't know how they're feeling. So under effect, you will say the patient's mood was da da da, but under emotions for effect, I could not assess because patient was wearing a helmet. So be practical. Make sense? So far, so good. I know it's a bit confusing, but I think when you start understanding it, you enjoy psychiatry so much. I hope. I hope you guys are not cringing behind the screens. Yes. So, Beryl, range and reactivity, as long as they are reactive entirely. So I think people get confused between range and reactivity, but reactive just falls under as a type of range that they're just reactive. It was just reactive entirely. Does that make sense? So I think people see it as two different things, but it falls under your range. When you have a good set of emotions and the person is sad, when you're talking about sad things, happy, you're talking about happy things, then that's a normal, full reactive person. So it's a reactive effect. Make sense? Oh, yes, Samantha. Thank you, thank you. Sorry, I have to scroll. Sorry, Samantha. Thanks for reminding. Okay. So Samantha asked, for those of you guys who might have missed her question, I'm just going to copy and paste it so you guys can see it in the chat box, okay? Okay, so she asked, can I confirm, in case we get a video for MSc and the examiner in the video did not ask the patient about their mood? Yes. So if you do not, now let's come back to that. Do I have the structure here? I'll come back to that. 1 second, guys. Bring you to the structure. Now, for example, if you didn't catch or the question of mood wasn't assessed in your station, you would say under mood. So in emotions, the mood was not assessed. The effect was, and you can tell effect because you would have seen how the person reacted in the video. So you can do effect on your own in your station, and then you move on. Now, many times, many doctors, they do not, I hope I answered your question, Samantha. Short answer is yes. Long answer, I'm coming to it now. So in your stations, many of you might not be able to finish your history, okay? For those who do not finish your history. So let's say, for example, you don't get to ask your insight, cognition, judgment question in your history, and then you move on to presenting your mental state exam. I need you guys to still say, right? So under appearance, behavior, speech, emotions, perceptions, when you reach IC&J, you must say under insight was not assessed. I could not assess insight. Under cognition, not able to assess. Under judgment, not able to assess. The reason why I need you to still talk about ICJ in your MSc presentation is because MSc presentation is a different marking scheme and rubrics compared to your history. So every task is marked differently. Your marks are different, right? Including your domain assessment areas in the exam. So history marks, yes, you won't get your marks for IC&J in history because you didn't do it. But when you talk about IC&J in your MSc presentation and say it's not assessed, you are actually filling up an answer to that. Therefore, you can accumulate marks for your MSc because you're showing the examiner, hey, I know the structure, and I also know I didn't ask. That's why I know that insight, cognition, judgment was not assessed because I didn't ask the right questions. Does that make sense? Now, when it comes down to cognition, your cognition question very straightforward, right? Do you know where you are? So oriented to place, person, and time. If you forget to ask place and time in your exam, but within the conversation and consultation, the patient mentions, oh, doctor, do you know this? Oh, doctor, do you know that? They mention the word doctor, they call you doctor. It means that this person is oriented to the person. So you can say that for cognition, patient is oriented to person, but I was not able to assess time and place. So a lot of MSc is based on how much story you get. Do not panic. Do not get worried if you do not get the full story. It is okay. You will still make it through the station. Okay, moving on to perception, thought, content, and thought form, the harder part of the MSc. Now, perception, thought, content, thought form. Perception is how the person perceives the outside world to be. So does my outside world have hallucinations? Right? So do I have any kind of visual, olfactory, auditory, tactile hallucination? So tactile means you can feel it. So very commonly in your cockroach case, like, oh, I can feel the cockroaches crawling on me. You have your visual. So visual is seeing things. Auditory is hearing things. Olfactory is your smelling, and gustatory is your taste. Now, olfactory and gustatory hallucinations are not very common compared to visual, auditory, and tactile, which is why the question that we use for hallucinations is, do you happen to see, feel, or hear things that other people can't appreciate? That is your perception question. So do you happen to see, feel, and hear things other people can't appreciate? That's just screening. If it's a positive, explore further. So now tell me, if let's say, for example, I'm a schizo patient and I tell you, oh yeah, doctor, I can hear things. What kind of follow-up questions would you need to ask someone like that? What kind of questions do you need to ask someone like that? If someone says they can hear, okay, what does it say? What does the voice tell you? What else?
Does it intimidate you?
Does it intimidate you? Yeah, you can, but more importantly is the command. So what is this voice telling you? Is it commanding you to do anything? You must make sure if this voice is telling them to jump down or throw the baby down or kill themselves, what is it exactly voice telling you? Now, Halima, you said about how many voices you hear. How, I'm not saying it's wrong, I'm not saying it's not important, but I'm saying how will that value add to our station? So how many voices you hear and is the voice familiar is not as significant compared to is it commanding you to do something. I, as a clinician, am more worried if it's commanding me to do something than whether I can hear 1, 2, or 3. Even if only person number 3 voice is telling me to jump down, it's still a problem for me. So it doesn't really matter how many voices I hear. It's more important on what are they telling you to do and what are the commands are. Okay, I hope that was a bit clearer. So this is where a lot of times we ask a lot of unnecessary questions. So if you want to decide if your question is necessary or not necessary, you would ask yourself, will this change my diagnosis? Will this change my management? What kind of information I'm going to find out about this is actually value adds to my case. If you can't find a justification, it's an unnecessary question, cancel, skip, move on. Okay, now let's move on to thought content and thought form, where it's a little bit more trickier. Now, these are various delusions which falls under your thought content. Okay, these are a couple of delusions up there for thought content. For those of you who might be confused on what is the difference between thought content and thought form, here's what it goes. So perception is how I perceive the outside world to be. Thought content and thought form is things inside my brain. So thought content is what are things inside my brain, and thought form is how are the things inside my brain forming, right? Thought forming, content is things inside. So what are the thoughts filled with, and how are the thoughts forming? So when you look at thought content, so inside my brain, oh my God, somebody's trying to harm me inside my brain, right? Somebody's trying to insert thoughts, somebody's trying to broadcast my thoughts, somebody's talking about me. So these are all just things happening inside my brain. That's why we call them as delusions. So these are different kinds of delusions. Now, how many delusions to ask when you're doing your history? Again, if your station is a station where the patient is already coming to you with hallucination and delusional features. So for example, they come to you, oh, doctor, can you hear the voice, doctor? Oh, doctor, you don't see that, doctor? How come you don't see that? So the minute you feel that this person is a bit funky at the beginning, you need to ask every single delusion question when it comes to your delusion part. So under your history section, right? When you do delusions, H, D, I, C, and J, under D, you ask everything. However, if your patient does not have any major delusional features at the beginning, no hallucinations, you just want to do a very quick screening of it, pick 2 or 1 of your favorite question, ask under your delusions just to show the examiner you are aware that delusions exist in the history psychiatry structure. So I usually pick thought insertion and thought broadcasting. I'm very sure by now you guys know that I move my hands a million times when I talk. So when I like thought insertion and thought broadcasting, because I move my hands, I'm like, anybody putting thoughts into your head? Anybody broadcasting? So because it suits my personality, I pick that question. Okay, but pick questions that make sense to you and pick the ones which is easy for you to phrase and say. Okay? So that's how you pick your delusion questions. 1 or 2 enough, guys, if you don't see any major features. But if something is positive, ask every single thing thoroughly. Any questions for delusions before I move on to thought form? Any questions? Now, thought, can you tell the difference between magical thinking and delusion?
Like we have to just ask these questions to the patient, right? When we
Say
are
again, sorry? Yeah. Yeah.
oh, okay, thank you.
So what do you mean by you mean ask every single one of them?
Yeah, yeah.
So again, if your patient already has features of delusion, yes, you want to ask every single one of them. But if your patient doesn't have anything, so for example, you're just doing a psychiatry structure of history because patient came with palpitations, right? And then probably it's a symptom of your panic attack or panic disorder or of your agoraphobia. You don't have a lot of time. So you know that it's not really something that is delusional based, right? Therefore, you just ask 1 or 2 questions just to show your structure and you move on. Does that make sense?
Yes, ma'am.
Yes, Abdul, question.
Oh, can you hear me?
Yeah.
Okay. So the question I had, for example, if the patient had hallucination and we further ask it was auditory hallucination, and we didn't further ask the patient had delusion of, for example, inserting thought or broadcasting, things like that. So when it's come to presenting to the examiner, so yes, we say that, okay, the patient had auditory hallucination and things like that. But when it's come to the delusion, so how can we form our answer or presentation to the examiner to say that this is the thought contents or the thought forms or things like that? So I'm a little bit confused here.
No worries. So again, it comes down to presentation of MSc, right? So when you
Mhm.
are going down your MSc structure, so percept AB septic, right? Your P, let me just go back to structure a little bit here. So P comes in first in your AB septic mnemonic. So P, under perception, auditory hallucination was present. If you think there was command, so auditory hallucination was present with commands. Finish. And then just move on. Under thought content. Okay, under thought content, patient had thought insertion. Thought insertion was present, and what kind of thoughts insertion, or what kind of broadcasting did he say that his thoughts were going onto the TV, or was it going onto the BBC News? So extra things that you find about, or let's say it's about ideas of reference where you say that people are just talking about him or his neighbors, or paranoia. So he can be under thought, under thought content, patient has paranoia where he thinks his neighbors are spying on him. So you list it off and then give your answer. Talk about where you are in your mnemonic first. So under appearance, in behavior, in speech, in emotions, under mood, under affect. So the way, because the exam marking score is very similar to this. If you look at the handbook and you look at Tally O'Connor, this is the structure they follow. Your answers are also presented in this structure. So it's easier for you to get your scores if you do that. Make sense?
Yes,
Now,
thank you.
before that, yeah, you get it. Yeah. So let me explain the magical thinking part of it. Now, magical thinking and delusions can overlap. They are not really the same thing. It is just people thinking that their thoughts or actions are not real. They're not connected to reality. Very, you won't really get these concepts in your AMC because psychiatry, again, is very straightforward, but magical thinking and delusions are two different things. And the thing is, magical thinking is something that is accepted by culture, but not something we accepted medically. So it's not really explained medically, but can be accepted by culture. And people who have magical thinking, they usually can have a little amount of insight. Does that make sense? Magical thinking versus delusion. Now, Amir asked about how to discern between preoccupations or overvalued ideas. They're very similar in your mania concepts versus guilt, but they're two different things, no? Why are we? What is the overlap that you're finding between these two things? Because delusional of guilt is when they're guilty about something, right? And then overvalued ideas is having very grandiosity based ideas, very big ideas, opening, oh, I'm going to rule the world. I'm going to open a 10,000 businesses in the next 1 week. That's overvalued grandiosity ideas. So just elaborate a little bit more on where the overlap falls in so I can help you break it apart a little bit more. Any questions for, okay, Sidra said, magical thinking, inside present. Hallucination and delusions? No, Sidra. Insight is completely based on insight. Hallucinations and delusions, most likely insight will not be present. You still have to ask your insight question. There can be overlaps. I can be listening and seeing people, but I also think I need help and I need treatment. So I do have insight. I know something is wrong with me. That's why I'm coming to see you because I'm seeing someone I know it's not normal. So I'm hallucinating, but I also am coming to you. So you can't really put that. So please don't memorize on this is more common and this is what happens. Yes, common is common 100%, but play by ear during the exam and fall back on your history taking skills to give you the answer. Not on sounds like this, feels like this, not going to work in the exam. Can't follow your feelings. Okay, need to fly a little bit more so I can cover MMSC, guys. I forgot that I have MMSC. Okay, any questions up till here before I tap about risk, rapport, and reliability?
Ma'am, thought form is like linear linearity. Is it
So if you and
ma'am?
yeah, sorry, for thought form, if I'm talking to you very normally, like normal conversation, yes, we can say that it's very linear, right? Linear conversations. Now, usually in people with schizophrenia, okay, when they are starting to talk about different things and all over the like they look down, they talk to the spirit, and they look at you, they talk to you. We usually use words like loosening of associations. So loosening of associations where their ideas are just all over the place. I actually don't have a thought form. The thought form slide is inside my head. I will. So before I give you guys a thought form, the slides, I will add let me just write it down to add the thought form slide. Okay, but it's just coming from my head. I will put it down for you guys. Halima, it falls under circumstantial, it falls under thought um, form. It falls under thought form because eventually it kind of reaches the point, but it's just unnecessary detail. And so thought form is this, right? How their brain is forming the thoughts. If they keep talking and talking and talking and they don't stop about talking, it's just their brain is just like that. It's very circumstantial. They just continue speaking and then eventually they end up stopping, right? So flight of ideas is another one that we use. Flight, so let me just type it down in the chat box for you guys. Flight of ideas is another one that we use for oh thanks Anita. Yeah, so flight of ideas is one that we use for mania people because they suddenly talk about A and then they go and talk about maybe G and then they come and talk about point number B and then they go back to maybe point number C. So they're just very confused. Doesn't confuse people, but there's just so many things they want to talk about. So it's your flight of ideas, very common in your mania patients. So I will put us, I'm so sorry, I forgot to put the slide for thought form. Okay, but I will put thought form slides up. Any questions? So yes, these are different. The ones that Anita are posting are different thought forms that you can use in your stations. Don't be too stressed about it. If you think that you're not able to figure out, just go for linear, not linear. If you can put in more effort to think about what kind of form they have. Even for example, if you can't think of the word flight of ideas because you just can't remember the word, just if the person's having so many ideas and so many thoughts, go back to basic English to explain yourself. Yes, it will take you a couple of seconds longer, but at least you convey your message to the patient. And even if you want to talk about loosening of association, that just means loosening together with reality, right? So we use that very commonly for schizo. You can just say patient is not in touch with reality or patient is responding to external stimuli. Responding to external stimuli is another way to explain hallucinations. So these are different words you can use. Okay, let me quickly do risk, rapport, and reliability, and then I'll come back to you guys, okay? Now, with regards to risk, rapport, and reliability, I know that many of you are not very used to talking about it. I need you guys to talk about it. And many candidates end up figuring out if the patient is high risk, low risk, or moderate risk. You must understand one thing. Many hospitals and many different places and many different clinics and WHO and all, we have different ways of ranking somebody with high risk and low risk. For example, rural areas, the threshold is slightly more lower compared to other places in terms of high, low, and moderate. People who have had previous attempts or previous histories, also the threshold is slightly lower when it comes down to ranking them into low, moderate, or high risk. Therefore, when it comes to risk, your only job is to say risk present or absent. Don't have to put very range because it's so difficult. What is low, what is high, what is moderate? Everywhere it's very different. So please just say risk present or risk absent. And there are many different types of risk I need you guys to explore in your stations. So the ones here are a couple of risks. The main ones that we know of are your suicide and your self-harm and harming others. These are the common ones. But other things are also having lack of insight, negligence, alcohol. So substance abuse comes in. So I wanted to talk a little bit more about alcohol here. With alcohol, right? Um, not aware of the safe limits is a risk. It's also a risk, okay? And having drink driving episodes or having any kind of trespassing is also another form of risk. So it just continues adding on to the list on top of your substance abuse. Same thing for your recreational drugs concepts. So please tap on these things when it comes to risk. Reliability. A lot of you guys also skip reliability in your stations. Have a little read and then I will elaborate a little bit more. So when you want to say somebody is having a reliable history, as long as they answer your questions, good memory, the insight is all present, answers are very, very consistent, history is reliable, but you do not stop there. So history from Amanda was reliable. However, I would still like collateral history to better diagnose and manage my patient. As clinicians, we are never happy with history. We always want more and more and more. History always has the answers. History always helps you in many different ways. Therefore, never be satisfied. If there is a room for you to get extra history, go charge at it. So even if someone's history is reliable, you would say that I would still, so history was reliable, I would still like collateral history from. Who are these people? So if within the history taking and story, you figure out that there were colleagues that they talked about, or they were family members they talked about, or in the STEM, they say that they were brought in by the police, or they were talking to the nurses, or the nurses involved. Your collateral history can come from all of these people. Does that make sense? Same thing when it comes to not reliable. If someone's history is not reliable, you can also talk about it was not reliable. I would need collateral history from whoever you found. So mention who is this person that you need. Does that make sense? Okay, let me look at the chat box very quickly. Anita, which part do you want me to repeat? So history was reliable. However, I would still like more history or history collateral. I'll type it on the chat box. I would still like collateral history. Okay, from. So you want to say collateral history from, go and figure out who this person is. Your story, the person will change based on your story. So it can be the nurses, it can be the policeman, it can be the friend, it can be the father, it can be the neighbor, whoever that you get. Yes, next of kin is another one that is up there for you. But make sure it makes sense. If the person says, I live alone, then next of kin is a bit funky. Maybe you want to go for nurses a little bit more. But there will definitely be someone. Colleagues are a very good one, actually. Colleagues or friends are quite a good one. You would definitely have asking a little bit about work or education. You would get those little pinpoints in your story there. Okay? Now, rapport is very straightforward. As long as someone answers your questions, they talk to you, they answer your questions, not too iffy about it, that is rapport. Any questions with regards to your MSc structure? So when it comes to presentation, I think Dr. Abdul asked 2 times about presentation. When you start, you just, ideally, I would love you guys, a strong candidate would give an introduction. So in the introduction, you would include the fact that I have a 37-year-old female named Melissa. Her history of presenting complaint was palpitations, maybe, or maybe it was tiredness, whatever the HOPC was, or fatigue, or feeling depressed, whatever. And then go under appearance, under behavior, So Halima, when you meant by guarded, what do you mean by guarded? Is it that they feel very restricted in terms of effect? Or is it position posture? So if it's a posture guarded, it would come under your behavior. But if it's a affect guarded, where they're very restricted in giving you emotions, then that would fall under your mood affect. So it depends on what you exactly mean by guarded. Does that make sense? Yes, in cognition, you must assess orientation to place, person, and time. All three must be there for them to say it's oriented to place, person, and time. What do you mean by memory? Memory is very MMSC concept. Cognition is just oriented. So delirium, cognition, you are looking for delirium, right? You're not really looking for memory, delirium. Now, one of the doctors did ask about overvalued ideas, guilt, and depression, guilt. Now, all of these still fall under your thought content. Okay, they still fall under your thought content of in your MSc presentation. What makes it different is that in your depression, guilt is used as a criteria to diagnose major depressive disorder. But if they are saying that their guilt, and they speak a lot about their guilt when you explore, it can also come under as a thought content of guilt. Does that make sense? And if it's a real situation, then it is a guilt overvalued idea. But if it's a situation where they're making up in their head, it becomes a delusional guilt. Does that make sense? So your concept is delusional guilt versus overvalued idea of guilt versus depression guilt. They all still fall under thought content. Overvalued idea of guilt just means that yes, it's present, they are guilty, but it's real. It's real and they talk a lot about it. But delusion of guilt is that it's not real, the situation is not real, but they are speaking about it. So it's a delusional of guilt. Whereas normal guilt for diagnosing major depressive disorder is also a type of thought content, but you put it under thought content and you can also put it under your diagnostic criteria. Does that explain the three different versions of guilt? Very complicated, I know, but if you look at them very carefully, the word itself gives you the differences. Overvalued idea, delusion of guilt, and just guilt for your depression, normal guilt. They all fall under thought content because that's what's happening in their head. So in fact, if you do want to look at thought content, there's so many things you can talk about because so many things happens in people's heads. Any questions about this before I run through MMSC Zook very quickly? Do you guys need a break? I think you guys can do, no? So this is very quickly put this question up for you guys. So I've been bringing tiredness and fatigue a lot to your stations, a lot in discussion today. So if you look at this station very quickly, okay, it discusses very straightforward. You look at it, you actually won't know if it's a psychiatry station or if it's a medical medicine and surgery station. Then you look at task number 2. You realize that task number 2 is asking you to present an MSc. Then you go like, okay, sounds like I need psychiatry questions to answer the MSc, but it does not mean you do not do your normal medical surgical differentials. So when you start your station, structure remains the same, but HOPC and organic causes will be more. So you would start the case by exploring tiredness very well. You would rule out organic causes. Now tell me, what kind, in the chat box here, what kind of organic causes would you rule out? Anemia.
Medical wise or psychiatry wise?
Organic causes. Thyroid, okay. Rheumatology.
Diabetes.
Okay, DM, fine. Brain tumor. What else?
Obstructive sleep apnea.
OSA, okay.
Chronic
Cancer,
fatigue.
fall. Okay, Hafsat put Hemifadok. Viral, Sidra said viral. Abdul said anemia, thyroid, DM, cancer, brain tumor. Fantastic. You guys are getting the hang of it. But my question is, do you have time to do all of this? You don't. You don't have time to do all of this in your stations. So therefore, two ways to handle this. First way, look at the gender, look at the age, see which one is more possible. In this case, someone's mic is on and I don't know who is it. Okay. So if you look at this case, so you would look at the age and the gender, try to rank a little bit. Yes, anemia was a very good one that you guys brought up to me. If she's still bleeding, okay, if she's still having her period. Cancer was a very big one. People brought it up, but not as common. However, Red flags would be nicer for you to bring up in general. So fever, infectious causes important for you. Malignancy, irregardless of whatever malignancy it is, your constitutional symptoms of malignancy needs to be ruled out in your station. Many of you gave me, not so many of you, some of you guys gave me mnemonics, right? So you have hemi, fed cop, fed dog, a lot of different things. But the one thing I want to emphasize is that, yes, I'm in menopause as well. The one thing I want to emphasize is this: mnemonics give you quantity, but that doesn't get you your marks. Because in your exams, you must show quality. So, which ones are going to be more common? Which ones are more red flags that I need to rule out very early in my station? If you are following this mnemonic of hemifed or hemifed cop, your D for depression is very low. So if you were to go down this entire list, you won't have enough time to reach depression. Therefore, a suggested idea, a suggested feature, an option is that you cover these five first. This is irregardless of whether it's a psych station or a non-psych station. As long as you have tiredness on the table, you explore HOPC of tiredness. So when one first time, intermittent, gradual, all of those questions finish, ask about fever, ask about malignancy. So screening question. I'm not asking you to diagnostic. So what does screening means? Do you feel hot? Right? Malignancy. Yes, Archie, I put skin discoloration there as well. Thyroid and head injury. Skin discoloration, Archie has mentioned as well. It gives you three differentials. Is it three? Hepatitis, hemochromatosis, and Addison's. Yeah, three. So it gives you three differentials. And if you realize, if you do your history of presenting complaint well, you rule out way more differentials. So if you ask somebody how long they've been feeling tired, you are figuring out acute versus chronic conditions. If you ask them if this fatigueness intermittent or is it like a continuous kind of a fatigue, you are thinking about what kind of fatigue things will be intermittent. Is it like a viral infection that comes once in a while? Or what's going on that only sometimes they are feeling tired? Is it work-related tiredness? If you ask them, is it in the morning or is it at night that it gets worse? Morning is your OSA usually gets worse. Insomnia, OSA, morning you're feeling more tired. But if it's autoimmune conditions, polymyalgia rheumatica questions, these ones are more nighttime you feel tired, right? Even at the beginning, when you ask, describe what do you mean by tiredness, and they tell you that, oh, doctor, you ask them, oh, is it like body pain? So you're thinking about fibromyalgia, myalgia conditions, or is it like insomnia, sleep difficulties, or just if you're feeling no energy and feeling low? So you are figuring out which direction to take, and almost 6 or 7 differentials will be covered at the end by the time you reach your head injury. The reason why I put thyroid and head injury up here for you as well is because apart from being tiredness factors, there are an overlap between your mood, your psychiatry stations, and your tiredness medicine surgical differentials. So let's say by any chance, after you ask head injury, you move on to asking D for depression. You would have covered a good set of differentials and you can easily fly into your psychiatry without thinking about, did I do enough? And you have also done your overlapping differentials of psychiatry and medicine and surgery, just thyroid and head injury. So it's a very strategically conceptualized 5 different things I need you to ask on top. Your red flags are also cleared when you do this. And malignancy, don't bother going on what malignancy it is. Just do your screening of loss of weight, lumps and bumps, loss of appetite. Once you finish that, then you move on to doing other things. If it's positive, okay, then now you need to start asking questions on this is a lady, maybe endometrial cervical cancers and breast cancer slightly higher. So I'm going to ask those symptoms first before I ask about other kinds of symptoms. Does that make sense? So these ones first, then proceed to the rest. Any tiredness cluster, adults especially. Pediatrics angle will change, but most of the time this one will work for you. Okay, I would love to give a brain break, but we are fighting against time. So I'm going to run through MMSC very quickly with you guys in the next couple of minutes. If you, of course, please grab water if you guys need water. Now, MMSC comprises of any questions up till now before I fly into MMSC. If not, you can collect them and ask them at the end. I do have a couple of minutes for questions at the end. Now, MMSC comprises So, Sumar, head injury is an overlap, right? They can feel tired. It can be a frontal lobe injury. So it depends on where exactly. It can be a temporal, it can be a frontal lobe. And all of this can cause personality changes or any kind of fatigue in them. That's why we put, and it's a red flag as well, which you cannot afford to miss. That's why we put it up there. Yes, so mental state exam is very different from mini mental state exam. They are two different things. They are not the same thing, right? So mini mental state exam is also tested very commonly in the AMC in different ways. It tests a person's orientation, their registration, attention, not their calculation, you can put it there, recall language, and their visual spatial skills. So let me show you a sample question and then we will take it from there. So have a read of this question. So if you skim through very quickly, catch important things will be 49 years old. Her name doesn't really matter to you. 49 years old, 7 standard drinks, past 10 years, only past 4 weeks, never drink. So not really a big deal. Only 4 weeks doesn't change much in your life. Non-compliant diabetes, which means can be uncontrolled DM going on. A lot of risk factors, a lot of issues in front of you. If you're going to do an MMSC is pretty much testing their memory and their cognition level. So you're thinking of, okay, maybe you have elderly-based Alzheimer's kind of dementia going on, maybe, or this concept might be a cerebellar-induced, alcoholic, cerebellar-induced brain injury or issue because it's been alcoholic for a very long time. It can just be age. So all these concepts needs to start coming to you when you read the STEM. Then you move on to task number 1. Task number 1 asks you to explain the MMSE. Not very difficult, just explain. Task number 2 is where your skills are being shown. Perform the MMSE. And if you look in the brackets, now AMC has a very big tendency to do these little things in brackets. Their font size might be slightly smaller. They might be in italics. When you are reading your STEM, they can be usually right at the bottom. Please read these things because they avoid you from wasting your time in doing them. Because if you don't read the part in the brackets, you would end up doing it. So for me in my exam, I think there are a lot of times in your physical exam where they will tell you something is done or don't do motor, don't do sensory. And if you don't see these things, you end up doing it. And then that kind of wastes your time and you could have been doing something else. So please read the things in the brackets. So in the MMSC, you don't have to score it. So MMSC is usually upon 30. Scoring, do you need to know it? You don't have to learn 100% how to calculate it, but I need you to roughly know what kind of a number is a good is a good mental state and which one is actually not. Reason is because sometimes in some of your stations, they will tell you that, oh, MMSC was 19 and then MMSC became 25 and then MMSC became 30. So you're like, okay, what is happening that this person is, the MMSC is improving? So if the MMSC is improving, a bit unlikely that it can be a long-term problem, right? It's more of an acute problem. So it can be based on cognition, your orientation questions, which is giving you the increase in score. Like patient is a bit drowsy, then suddenly, slowly, it's becoming better. So those are concepts to know when you look at an MMSC. Okay. Now, this is from the, where did I take this from? The handbook. It's a very long explanation of what the mini mental state examination is. Okay, so the questionnaire wise, I'll come to it. So it really depends on what AMC is testing you. Most of the time, in fact, most of the time, they have given the questionnaire to you, but the frontal lobe portion is not given to you. So I will touch on the frontal lobe portion. It's always based on memory for that one. Now, there's two different versions of the mini mental state examination. There's the older version and the newer version. Okay, two different ones. So the newer version has questions for you to ask. It has a very beautiful script. So let me just quickly show you the newer version. Okay, so this is the new version of your mini mental state exam. In the new version, it's so beautiful, right? They tell you exactly what to say. So we usually call it the standardized version because it makes it very standard for everybody, whichever part of the world you are in, wherever you are working, you use this question pattern. Whenever you are doing the mini mental state examination, do not input your own emotions. Do not put your own opinions inside. So what do I mean? For example, if you ask somebody, your patient, oh, so what is the year today? What year is this? The patient goes 2020, and then you go, yes, you can do it. Come, think, you can do it. No, you are not sharing. You cannot add any of your emotions, which is why we call this the standardized version of it. Okay, no emotions. There's no mnemonic, unfortunately. Usually it's always given to you in the exam, to be honest. So this is the standardized version where you have, can you guys see, you guys can see my screen, right? I'm showing the standardized version. Okay, correct. Yes, so here it tells you, so read exactly what you see on the screen or the paper that's given to you for the standardized version of the mini mental state. Okay, let me just put the link into the chat box. Okay, yeah. But let's go to the old version. Now, when does AMC give you which one? That's the question. If AMC is testing you on do you know what are the categories? So if you look at the new version, it does not tell you the category. It does not tell you that the first part belongs to orientation. It does not tell you that this one is on registration and this is on attention, this is on recall. So if they are testing you on do you know why are you asking the question, they will give you this version of the MMSC. How, okay, this is the version, one of the versions. But if the AMC decides to, I want today for this station and this exam, I want to test the person on how they are asking questions, then you will be given the other version. So let me find the other version for you. This is the other version. Now, the other version, if you do realize, this is the older version. It does not have any script for you, but it has the category. So they're not very concerned about you knowing the category. They're more concerned on that day. I want to see how flowingly does my candidate know how to phrase the question? How is their command in asking question? How is their communication? That is the priority. So your predominant assessment area will change depending on what they want to test from the station. Which brings me to the point that many people say that, oh, it looks like I know this station. Why did it become a pilot station? I see this all the time in the recalls. Well, the reason is very simple, right? Even if it's a word change or a grammar change or a change in time or a change in words like explain, discuss, mention, give, this is all affecting the way the candidates present the station. And it's not a concept that they're testing you on, but how does this affect the change is what they're trying to figure out in a pilot station. So you guys think that just because I've seen this case before, it's not a pilot, but it can be many things that they have changed in the station. They're going to even change the predominant assessment area. Maybe it used to be history, now it's management, therefore it's becoming a pilot station. So the thing is, you can't predict a pilot station until your results are out on that day of the exam. There's no way for you to predict it because there's so many things that are being done. And if you do look at a recall, you would the candidates are not strong enough to tell you the exact timing. I mean, I'm not saying they can't. It's so much to remember. Okay, it's not their fault at all. It's just so much to remember. It's very overwhelming. And I'm sure for those of you guys who have done the exam, you know that you can never remember 100%. So timing makes a difference. Question phrasing makes a difference. A lot of you guys just say history, MX, DDX, DX, but that's not everything in a station. What about it? Sometimes stations ask you for causes. Causes are not the same thing as differentials. They are two different things. Causes of the diagnosis, for example, if I tell you I'm having a migraine, people put DX, but causes of a migraine is different from differential diagnosis of migraine. Causes of migraine includes the trigger factors. Differentials of migraines is different types of headache, right? Your cluster, your sinusitis, temporal arthritis, all different things. So these are things which your recallers don't catch. And this is exactly what's happening in the exam when you memorize a recall and you go in. So this is your second version of your mini mental state exam. Now, let me reverse back. Here, for the first part of the task, it asks you to explain what MMSE is to the patient. As long as you cover these concepts, enough. Just tell me that it's a screening tool. It is not a diagnostic tool, so you can't use it to diagnose. We are just testing you for memory, attention, concentration, and your orientation. Let the patient know that it's very simple questions and simple tasks. It takes about 5 minutes to complete it or even less than that. We usually score you out of 30. And you want to reassure your patient that it's not really a pass or fail. And then you can proceed on. So I have a little paragraph that you guys can consider using for explaining an MMSC, but essentially, if you think there's already so many things to memorize for AMC, just stick to understanding what is it and then deliver it accordingly. Okay? Before you start, many people forget this. You must ask for consent to proceed. And you must also ask if there are any troubles with hearing or vision. Because if you know your mini mental state exam, you realize that there are times it's a hearing test. I mean, not a hearing test, but you need to ask them questions and need to answer you. If they can't hear you, then how are you going to do it? You might either change your position, go nearer to them, or find ways to make yourself sound louder. And vision is also important because there are stations or the task rather than the MMSC at the end where you will write a sentence, close the eyes, and then they need to close their eyes. They also need to draw things and write things, and all of this will be affected. If they can't see, then what are they going to draw? What are they going to write? Therefore, check for hearing and vision, get consent, and then start your MMSC. Now, orientation, very straightforward. Okay, 2 different versions I showed you guys. Do not add your emotions. Every one of them is 1 point. This is where I want to spend a little bit more time on. Now, this is the older version. The older version of the MMSC will ask you to name 3 objects, right? And then you will repeat them: apple, table, and coin. Once you say them, you wait, ask the patient to repeat. You will take the scoring on the first attempt. Scoring of the number of correct words repeated on the first attempt, but you need to repeat all of these words until the patient has learned them. So what do I mean? You would say apple, table, coin. Can you please repeat? Then they will repeat. If they go apple, coin, doctor, I can't remember. Be patient and go again. Apple, table, coin. Then once they say apple, table, coin, you proceed on to your next questioning. Now, question for you guys. Look at number 3. Okay, this is the new version of your registration. The sentence is very clear. So I'm going to name 3 objects. When I'm finished, I want you to repeat them. Remember what I asked, because I'm going to ask you again them later in the next few minutes. Then you say ball, car, and men. My question is, why is there other words here? Why is there bell jar fan, biltar can, and bull bar pen at the bottom? Why do you think there's so many words there? Why the older version only has 1 set of words and the newer version has so many words? Anybody in the chat box? Any ideas are fine. As long, show me that you're thinking a little bit. Try to think. I know that I've squeezed your brains the past 2 hours. Yes, Liba. Similar sounding, but okay. Joshua said, so patient won't memorize. Yeah, getting there, Kathleen. Joshua said more options to choose from. Nairi said skip repetition. Okay, you guys are close, not super close. Now, first of all, someone said similar sounding. So Liba, for similar sounding, yes, I agree with you. The reason why the newer version has a similar sounding is because the brain responds a bit better to that through research. All R and sounding phonetically sounds better in the brain. So that's the reason why they sound like that compared to the older version. Now, different of shades. That's a lot of thinking, Lala. I've never thought about that. But let me give you guys why there's a repeated use. So for example, okay, when you do an MMSC, you are checking for short-term memory and long-term memory, right? If this person did an MMSC with your colleague that morning, your colleague would have used ball, car, and men. And then now you are doing the MMSC 24 hours later, or let's say 10 hours later. This person might remember the word ball, car, and men. Therefore, if you are the second person of the day or of the particular time zone, or within a couple of days, you're doing the MMSC again for the patient, you would pick a new set of words because ball, car, and men would have now become long-term memory storage for your patient. Make sense? Want me to repeat? Question mark. So if the stem says that in the morning, Your colleague did the MMSC with your patient, but it was not completed because your patient was in had tummy pain all of a sudden, or the patient had to go to the toilet because patient was having diarrhea. Then when you are the second person doing the MMSC for the day or for the couple of days, you would now pick a new set of words. But if you're the first person ever doing MMSC, you would just pick your Balka and Men, very straightforward. Make sense? That's why we have many, many options for you to use from. Okay, just in case it falls into their long-term memory. Scoring is done on the first time. Remember that. Okay, the newer version is a little bit more instructive, so do look at the newer version of your MMSC. Now, let's move on to attention, concentration, and recall part of the MMSC. Attention and concentration, I usually prefer saying spell world backwards. I think it's easier for me because I struggle with maths, and I think I will also have problems asking them to do serial of sevens backwards. I will definitely struggle with that. So you ask them to spell world backwards. The number of letters in the correct position is the number of score that you give. So I'll bring you to the newer version where I feel it's a bit easier to explain this section. I really think the newer version is much better, so I hope you guys get the new version, but it really depends on your day. So in the newer version, they're a little bit more encouraging. They give you the room of doubt or benefit of doubt that the person might not be language or linguistically strong. Therefore, they first ask you to spell the word world. So you go forward first, then you tell the person, now spell it backwards. This is when you start your timer and you start counting. Make sense? So if it's, let's say, for example, if I spell as D-L, so D-L-O-R-W, so 2 words in the wrong position, 3 words in the correct position, you would score me 3/5 because I put 3 letters correctly and 2 letters wrongly. So number of correct letters is your scoring on the first attempt. And you only need to do this once. It is not like your number 3 where you need to repeat many times. And for number 3, Hafsa, you asked about it. Yes, Hafsa. So you would take the scoring on the first attempt. So scoring on the first attempt, okay, but maximum of 5 times. Then proceed and move on. Okay, I hope that answered your question for the Balka Men part of it. So far, so good. And of course, for recall, it's just asking them to repeat the 3 words that you mentioned previously. See if they're able to remember. 5 times, 5 maximum. Scoring is on the first attempt. It's up on 3 because it's 3 items. Maybe that's why you're confused with 5 and 3. Now, with regards to language, a lot of things to do, just follow the instructions, very straightforward. This is where close your eyes. A lot of you, please write close your eyes in capital. Please write it big on the paper. So if you're an A4 paper is always given to you in every station. So write close your eyes and then show it in front of the patient and ask them to read it. A lot of you like to put it in front of your face. Obviously, if you put it in front of your face, you can't even see what the patient is doing. And once the patient has closed their eyes, before you move on to your next task, you need to ask them to open their eyes. So once they follow the instructions, ask them to open the eyes and then you continue on with your station. So very, very little nitty-gritty things that people often miss out, but I hope that you guys will do it after this session. Now, these are all various versions of the language, but it's very straightforward. You just have to follow. So what is this called? These things will already be provided on your table, your pen, your paper, your pencil, whichever is it, and then just show it one by one and ask them to mention what is it called. Ask them to repeat the phrase after you. No ifs, ands, or buts. I've done the MMSC with a lot of you before, and many of you guys either say it very quickly or you guys forget the or. So be slow, be clear. You have time to do this. Now, the one part that I wanted to mention was this frontal lobe functioning. You don't have to do the frontal lobe functioning all the time unless the task asks you specifically to do the frontal lobe functioning. The AMC will ask you as a separate task. If not, the MMSC does not come together with a frontal lobe function. And frontal lobe function, if you don't know it, it's very hard to do it, which is why I'm going to cover it. There are 4 sections in your frontal lobe function. The first one is your verbal fluency test. Now, there are 2 different ways to do it, but there is a preferred method to do it. The first way is to give them 1 minute and ask them to give them a letter and say as many words starting from that letter. This is something that I struggle with because on the spot, if you put me in and you're like, love, tell me all the words starting from P, then I'll be like, I don't know, purple, potato. And even if you go and test yourself, you wouldn't be able to say it very quickly. And you must be able to say at least about 15 words each. And there are 3 different letters, so it's a bit difficult. Therefore, the easier one is the second part of this, where you give them a category. You give them a category and ask them to name as many things as possible from that. So tell them, give me different types of animals that you see in the zoo, or tell them fruits that you will see in the supermarket. This is a bit more easier to think about visually as well. So I prefer using the category method compared to the give the letter and ask them to figure it out. See what works for you. Okay, see which one is easier for you. The role player will be prepared for both, so no issues about it. Now, the second part of your frontal lobe function is your proverbs or saying interpretation. Now tell me, what do you guys understand by a bird in the hand is worth 2 in the bush? Now, this screenshot you see in front of you is from the handbook. It's from your AMC resources. So what does this quote mean? A bird in the hand. Don't Google, don't chat GPT. Okay, don't Gemini, don't whatever. Just try to figure it out on what does a bird in the hand is worth 2 in the bush. And think about how you will try to explain this to yourself. To be very honest, I struggled to explain it the first time, so I use other quotes. Anybody want to give it a shot? Yes, Sidra, very hard, right? Now, so I've given you options. So these are, what you have is better than what, it's not really what you have is what you see, then what you see is better. Yeah, similar to having an opportunity in the hand is better, having some, at least one is better than having so many options, but you can't even reach them or you can't even use them or you can't even do anything about it. Right? So it's a bit hard to explain. I myself struggle with it, which is why I love things like don't cry over spilled milk, right? Or the early bird catches the worm. So please find things which is easier for you. Yeah, I think Jendi is similar. Something within your grasp is more important than something that you can't even reach. So so it's a bit difficult to explain that one in the handbook, but these are all options that you guys can use, which I feel might be easier. I love you can't judge a book by its cover. I think that one is very easy. So find something that suits you, memorize it, keep it. Even a stitch in 9 saves time is another one where if you act early, it prevents you from getting bigger problems or from the problem getting worse than expected. So see what works for you. I like don't cry over spilled milk. The early bird catches the worm, and you can't judge a book by its cover, but just one is enough. Okay, don't go and memorize so many. This is not an English test. Okay, this is just a normal frontal lobe examination to see if they can understand stuff. Okay, so with that said, so that is your proverbs or sayings. Now the next part is similarity and differences. You can either use only one thing, guys. Don't have to say so many things. So apple and banana, table and chair. I like to use aeroplane and bird. So as long as they tell me it's living thing and non-living thing, I'm happy, and then I move on. So at least we can tell you one similarity and one difference. Enough. Move on in those things. Okay, don't have to wait for so many similarities or differences. One. Pick whichever you like. I like, as I said, bird and aeroplane. So they both fly. Then one is a living thing, one is a non-living thing. Enough. Now the fourth part of your frontal lobe functioning is your Luria step movement. Do they have that? Yeah, it's called where is it? Luria, yeah, Luria 3-step hand movement. This is what the Luria 3-step hand movement is. As long as they can do it a couple of times quickly, you are good. Your frontal lobe functioning is done. So frontal lobe functioning can be done in MMSC. Usually frontal lobe functioning patients do have personality changes. It can come after a head injury, it can come after stroke, it can be a fall, it can be a hit during sports. So all of this can cause a frontal lobe dysfunction. So if you guys are interested and if you see somebody in your hospital who has a frontal lobe injury, you can go and try this on them. There'll be a little bit of discrepancy. It'll be quite fun to try on them. They can sometimes with frontal lobe functioning, they can become more aggressive people. There are some people who start becoming very, very generous because it really affects their personality. And I don't know if you guys read the news. Can't remember a couple of years ago, there was this guy who had a head injury, and it now started tapping into his temporal lobes, which helped him and in the frontal lobes, and it helped him start to see things very geometrically, very visual, okay, very spatial, visual, geometry wise. So he used to be really bad at math. And then after his head injury, he became good at math because his brains in the math part got activated. So no, not that I'm asking you guys to hope for an injury in your head so that the AMC part gets activated, but these are real life stories, which makes medicine very interesting and exciting. Now, any questions that I missed from today that you guys have for me? I might have missed, so just please shoot them again. Now, based on questions that I wrote from the beginning of this session that you guys asked, I covered the confidentiality part of it. I hope I covered the rapport. And with regards to role player opening up, I can't remember who are, and handling role player. Now, confidentiality is one way to get through it. If you still don't get it, then don't worry about it because the exam might just be the task or the marks might just be going into seeing how do you actually approach your patient when things get difficult. So it doesn't quite matter, right? Don't worry if they're not opening up even after confidentiality. That might just be how the station is run. Question, Sidra, is this all psychiatry? No, Sidra, this is what I've done is, well, I've done history, I've done MSc and MSc. You still have a lot of other clusters and disorders to look at. So you have mood disorders with your depression and mania, bipolar concepts. You have anxiety clusters, which has your OCD, OCPD, PTSD, GAD, generalized anxiety, and all of that. So I would say this is maybe about 30%, but the structure kind of puts you ready to tackle the remaining 60 or 70% that is in part of psychiatry. Yeah. Now, Lakshmi asked, will they ask? Yes. So, Lakshmi, if they wanted to do frontal lobe, they will specifically say to test frontal lobe functioning. If they ask you to do the MMSC is only part of 30 points. It's only your questionnaire that you have. You don't have to do your frontal lobe. Now, frontal lobe can be asked with MMSC plus frontal lobe. It can be asked in stations where head injury was involved and one of your tasks is to test on frontal lobe. It really, really depends. Now, in the exam, if you do look at cases that comes in, psychiatry is about 2 to 3, not more than that. However, psychiatry concepts will be nice to touch in every single station if you can. So for example, as I said, if it's a medicine and surgical station on palpitations or shortness of breath or chest pain, you can always ask one question on how's your mood like lately because you do have anxiety in those ones, right? So please. So for frontal lobe, it's these 4 things, Amber. Yep, these 4 things. So the first one is the verbal fluency test, which I usually use categories because I find it easier. Second part is getting your proverbs done. Your third part is the similarity and difference, where I think bird and aeroplane is quite nice to use. And then you have the motor sequencing test. So Dr. Street, do you have to remember every task in MMSC? No. You don't have to remember every single part of it because in both versions it is given, but do have a flow with no emotions to ask them and know which questions belong to what category. So what am I trying to rule out from this portion? What am I trying to, am I doing orientation? Am I doing registration? You need to be very clear about it when you do the MMSC. Any other questions you guys have?
Excuse me, in MMS's case, do they provide us any chart or do we have to remember all these points?
They provide, but whether they give you the old version or the new version, it depends on what they are testing you. So if you look, the new version has a script, but does not have the headings. But the old version has the headings, but not very good script. And it does not really explain to you very much of the scoring system. So know roughly, but the question is always given to you.
So, how to do scoring? Suppose if in this case of orientation, if patient says two
Yeah,
things
everything is just one.
correct.
Everything is just one point, right? So if you look at, if you can you see my screen?
Yes.
Okay, cool. So every question, so the thing is, MMSC takes a very long time to actually do because every part is like you ask the question, you wait, get 1 point, ask the question, wait 1 point. So it's really one by one.
Okay. Okay. Thank you.
But however, they have never really asked you to score the MMSC in the exam. But you need to, as I said, you need to know what the score means. If I tell you that the score is, for example, 20, then you're like, okay, why is it 20 over 30? What's going on? Something is wrong. Then, and as I said, over time, right? If it was 19, then 25, then become 30, usually it is your orientation that can improve. It's very unlikely for somebody's short-term memory to and long-term memory to improve immediately, acutely over a couple of hours. It's very difficult for those things to happen. So this is where your analysis as a clinician starts coming in. You're welcome, guys. No worries. I hope you guys learned. I hope you guys. I know it's a lot to take in. Okay, super a lot. Yes, you have to be familiar with both versions of the MMSC. If you wanna ace the MMSC, you have to be familiar with both. Don't
So
leave one.
in so
Mm.
in the end of this case, we have to count all these points and tell the score and interpret.
No, so let me bring you back to the station. 1 second, where's my station? Here. You're welcome, guys. So if you look at the station here, I specifically will tell you no need to score, right? And then it tells you that the last two tasks have already been done and it's normal. So your job is not to score. Your job is just to figure out what went wrong in the middle. And in this case, usually what happens is this. Orientation is normal. Okay, orientation, there's no problem because she's oriented to place, person, and time. The other thing that is an issue is that she will not, her memory will have issues because she's been drinking for a very long time. There's alcohol brain induced injury. Therefore, her memory, she won't be able to remember the three words that you tell her. And her attention, so the way she spells the attention and concentration, the way she spells the word world backwards will also be wrong because alcohol will affect, dementia will affect these kind of little things. So she have a problem in registration, in recall, and also a problem in attention most of the time. Sounds good, Salman?
And what are the scoring systems? Like every MMSC station is one 1 mark or 2 mark?
Here. It's different, right? So most of them is 1 mark, 1 mark, 1 mark. But if you look at like the other ones, like the spelling word is 5, the number of words to repeat is 3. So it does change in the middle part, then it becomes to 1 1 1 1 1 after that. So
Thank
refer to the link that I sent. For those of you who missed it, I'm just resend the link. And also just a reminder that MedExam Expert is doing on 3rd July, they're starting a 3-month course for AMC2. Okay, let me just look at the other questions. Yes, you guys will be getting the recording. I believe if you guys have registered. So some of you guys got the links and just joined the Zoom through the link. But I believe you need to register so that they have your email. So the MedExam Expert personnel can email you the recording. Please contact them personally in the chat box so that you can get their emails to them. Yeah, WhatsApp them. I think that will be the best way to reach out. Other questions. In the recent exam, MSc was about non-epileptic. Now, for Abdul, this one I need to clarify a little bit more with my doctors who sat for the exam. I'm getting them to recover from the exam before I start speaking a little bit more and disturbing to them about it. Now, you must understand that, so for the non-epileptic, usually it is your pseudo seizure. So it's your conversion disorder. That's the most common one. So in a conversion disorder case, you need to be able to rule out your organic causes of why someone is having epilepsy or why was there any jerky movements. After ruling out everything, then only you say that it's a pseudo, right? It's a conversion disorder. And it happened because there was an emotional trigger. So he was either going to get caught because he was stealing something and he was going to get caught, or whichever reason that caused your pseudo seizure, your conversion disorder. So presenting the MSc wise, MSc would actually be pretty normal, no? MSC would be pretty normal in a situation of a non-epileptic seizure from the looks of it. Unless, of course, once you watch the video, you'll figure out more. So don't be worried to present MSC on a relatively normal patient, because then it just means the exam is now looking at for, are you able to know the structure and do you understand MSC? They're not so particular about the way you explain things in the middle. So every MSc is testing you different things. No MSc is testing you the same skills. Sometimes I want to see how good you are in history. Sometimes I want to see how good you are in instructive MSc. I want you to see whether you know what is normal and abnormal. Do you know what is involved inside the MSc? So don't panic if your case looks a little bit different from normal. Yeah, it can happen in the exam. Tuan asked if you must remember all the questions. The answer is no. MMSC sheet is always provided, but I need you guys to know how to ask the question and know the headings. What else? Okay, I think I covered most of the questions. I'm trying to scroll. If I missed anything, please do post. I hope you guys learned. I enjoyed. I always love psychiatry, so you will see me very
Yes,
energetic.
it was such an amazing session, Dr.
Oh,
Lavanya. I
thanks,
loved it. I
Asta.
loved it. And and we had a huge audience today, and I would really want to appreciate our audience as well. They were
Oh,
really, encouraging, and they were asking the question. We really want this kind of audience in every webinar because we are arranging these kind of sessions for them. So,
yeah.
Dr. Lavanya, and also it was a great, great session from your side.
Thanks, guys.
You
And
have
yes,
covered some things. Yeah.
you
And
guys were
also, Dr.
great too.
Lavanya,
Yes.
yeah, we have to also let them know about the courses that we are offering for the clinicals so they can join you for
Mm-hmm.
their preparation for the clinical exam. So for AMC Clinicals, we are offering regular course that is starting from 3rd of July with Dr. Lavanya and Dr. Kiran Sindhu. They're going to take live sessions with you and they're going to make sure your all topics are cleared, well prepared, so that you can sit in your exam confidently. And also, if you want to book one-to-one sessions, especially with Dr. Lavanya or Dr. Kiran Sindhu separately, we have that course as well. Or you can, book a trial exam with Dr. Lavanya as well. So if you want any details, we have shared our WhatsApp numbers. You can contact us and we can guide you about all these amazing courses. I guess we can wind up, Dr. Lavanya. What do you say?
Yes, yes. Thanks, guys. And you guys will get the slides. The slides also includes the alcohol and smoking aspect of things. So you guys can refer those part in the slides. Thank you
Yeah,
for
and
being
if
super,
anybody
super
wants
interactive.
recording, yeah, if anybody wants recording, we can provide that. So
Hmm.
just contact us and we're going to share the recording with you till tomorrow, okay? Thank you so much, Dr. Lavanya. Thank you
Okay,
so
see
much,
you guys.
everyone.
Bye. I'll stop my share.
Bye bye. Take care.
Bye.